Hello, hello, hello. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. It is Sunday, April 21st. It is Easter, and it is time. And normally we would do a support group meeting, and I am here for a support group meeting. However, I have no idea if other people are going to be doing Easter things. So I thought I would just drop in and see if there's anybody who needs some help because IC knows no holidays, my friends. It's very common for patients to have flares on holidays when there are family gatherings and other things that are supposed to happen. So let's just take a moment and see if there's anybody out there on this gorgeous spring Sunday, one of the nicest Sundays we've had here in California. Hello, Corrine. How are you today? Happy Easter, happy Easter, happy Easter, happy Easter, everybody. I don't know if I'm going to be able to go to our Easter celebration here in our family because I have to stay with my parents. My dad's not feeling too well today. Probably because the little Easter pastry I got for him was a little too sweet. It was too sweet for me, and I think it's a little too sweet for them too. Hi, IMD. Hello, Donna on YouTube. Hi, JJ. Nice to see you. So let's just give it a minute or two. Let some people come on in. And we will go from there, my friends. Hello, Sue. Hi, Julie. Oh, I'm so glad that there are some people out there. You know, as I was saying, IC doesn't know holidays, unfortunately, and it's very normal for IC patients to flare, especially when you've got an expectation of being with family, and yet, you know, you've got to drive and all that sort of good stuff. That definitely makes it challenging, right? Am I right? Yes. Hold on one sec. I'll be right back. Hold on. Let me just check on him. When you're 96 years old, life is challenging. He's okay. It's okay. Life is good. So how you guys feeling? You know, I'm going to confess I had a flare. You know, I don't have a lot of flares these days, but I've had this yeast infection thing. We finally got the yeast infection under control, but a note to self, my friends, I've got two essential survival tips for yeast infections. Number one, don't leave a heating pad in your bed in the middle of the night because you create the perfect environment for yeast to grow. And at night, if you wear underwear, change it every night when you have a yeast infection so you don't reinfect yourself. Hey, man, you know what? Listen, I'm willing to talk about anything. I am not embarrassed about anything. Unlike when I was in my 20s, I would never have talked about any of this, but you know, age has wisdoms. Age has wisdom. As I say to anybody in my family who's struggling with bowel issues, I promise you, you will have a bowel movement again. We're just going to get through these little short hurdles, like little yeast infections, little bladder infections, all that sort of stuff like that. So the purpose of doing these meetings, as you know, is to make you so strong, so knowledgeable, so informed that you can go in and advocate for yourself with doctors. I don't want any doctor telling you that IC is all in your head. I don't want anyone minimizing you. I want you to be able to defend yourself. I want you to be able to kick ass when somebody's messing with you. I want you to be able to stand tall, stand strong. You know, there is no shame in having interstitial cystitis. You're no different than someone who is hit by a car. You're hurt. And part of the challenge is trying to figure out where you hurt. Are you hurt in your bladder wall? Are you hurt in your pelvic floor? Is there a neurological injury? As I say to everybody, you are an anatomical mystery to be solved, right? And we are kind of long past those days of thinking that interstitial cystitis is, in fact, a incurable bladder disease. We no longer think that. We now understand that this is a syndrome. What that means is that there are other structures in the pelvis that can influence bladder function and prostate function. So now we're doing something called subtyping. We're trying to understand what unique variation of IC is so that we can focus on the right treatments for you. Because if there's one thing we know for sure is that a one treatment fits all approach does not work. Elmeron does not work for everyone. In fact, Elmeron works for very few people comparatively. Tell you what works far more than Elmeron for far more people is pelvic floor physical therapy. Why? Why would a muscle therapy, God, my hair's all weird. Why would a muscle therapy help a bladder disease? That doesn't make sense. Well, maybe it's not a bladder disease for some of you. Maybe it is, in fact, a muscle dysfunction, a muscle injury. Because guess what? When your pelvic floor muscles are injured, it influences bladder function. You will have frequency, you will have urgency, you will have pressure, you will have burning, all from a muscle injury. So again, you are an anatomical mystery to be solved. We have to figure out what your unique variant of IC is, right? Right. So here, hold on a sec. Let's see here. I was kind of running this morning, so I couldn't set up my office quite like I normally do. So let's do this because I am hoping that maybe out there, some of you might have a family member that's watching too, right? So let's go over the subtypes. Why not? Let's do it. So in Europe, the European Society for the Study of Bladder Pain Syndrome has 12 variants of IC, up to 16 variants of IC. So if you happen to be in Europe, you would be, they would look at your symptoms, they would rule out pelvic floor, they would rule out viral infection, they would rule out other stuff. It's a very exhaustive process. Then they would do a hydrodistension and a biopsy in your bladder. And based upon what they see in your bladder and your biopsy results, you are given a ranking in Europe. Okay, we don't do that in the United States because our insurance companies won't pay for it. What is going on with my hair there? That's so funny. It's standing straight up. In Canada, they use something called the U-point system. The Canada Urology Association's guidelines for IC require that patients be subtyped using the U-point system. And when U-point came out more than a decade ago, we were all like, oh, hallelujah, finally, somebody gets that IC is more than the bladder. So in the U-point system, they ask doctors to look at your urinary symptoms. They ask them to look at your pelvic floor. They ask them to look at the condition of your bladder wall. They ask them to look for other related conditions. They ask them to look at any anxiety that might be going on, because that can be a part of it for one of the subtypes. And there's one other thing there. Okay. And so with the U-point system, if you wanted to learn more about that, you can go to upointmd.com. And that's been validated in multiple research studies. And again, the Canadian Urology Association, that's what their diagnoses of IC is dependent on. I don't think that there's a subtyping system in Japan. In Japan, IC is known as hypersensitive bladder syndrome. Remember, we have also been on this 25-year debate on what the hell do we call this, right? Are we going to call it interstitial cystitis, which implies that there's a problem with the interstitial layer of the bladder wall, which certainly is not true, but that's the name we've had for 100 years. Or are we going to call it painful bladder syndrome, bladder pain syndrome, urologic chronic pelvic pain syndrome, you name it. Man, there's a hell of a lot of names out there. Don't get obsessed by the names. Okay, so again, in Japan, in Korea, in Australia, in New Zealand, I don't think they have an agreed upon subtyping system. However, in the United States, we have really bold thinkers here in the United States. And one of the boldest thinkers is a lovely doctor named Christopher Payne, who ran the IC research program at Stanford University. And several years ago, he presented what he believed our subtyping should be in the United States. But he introduced it in a really provocative way. I mean, it really got your attention because he said, we should treat IC patients like cancer patients. At which point in time I went, whoa, don't mention cancer. Seriously, that's scary. And there's no relationship between IC and cancer. And his answer back was, no. I want you to think about it differently. If someone who's diagnosed with cancer, they're not just told you have cancer. They're told where it is. So you have cancer of the left breast. They tell you the type of it, estrogen dependent. They give you a variant, type 1, 2, 3. And when you're diagnosed with cancer, you have such a specific diagnosis that you and your doctor know exactly what to do next. There is a clear and intuitive treatment pathway when you have a diagnosis of cancer, because they know that's how you save lives. And he argues very, very successfully that a diagnosis of IC is pretty meaningless because it gives you no intuitive pathway. You're diagnosed with IC, what the hell do you do next? Your doctor doesn't necessarily know what to do next. You don't necessarily know what to do next. The vast majority of you are going to be given Elmeron and thrown on your way. Or some of you are going to be you're going to be given low dose antibiotics or whatever. Okay. So how do we create that specificity so that you have an intuitive pathway? Hold on, somebody is opening my door. Hold on, you might get to meet. Hey, you want to meet my 90-year-old mother? We are broadcasting a lot, Mom. Mom, look, we are live right now. The world can see you. You gonna say hi? Say hi.
Hi, hello. Happy Easter.
She says happy Easter if you don't hear her. Out in the garage, in a bag. There's a bag out in the garage. Just right outside the door, okay? Shut the door. I will tell you, listen, guys, my mom saved my life. Hold on. When my IC started when I was 32 and I could barely walk, the pain was so bad. You want to know who drove me to the doctor? That woman. You want to know who drove me to San Francisco every week? That woman. You want to know who came with me to a lot of IC conferences because I was afraid to get to the airport, thinking I'd have to stand in line when I need to go to the bathroom? That woman. The IC network would not be here if it were not for that woman. And it is such a tremendous gift to be able to return the favor to her and care for her now that she is older, right? Because she's 90 now. And so, yeah, there you go. That's my mom. Also, if you're wondering, I'm actually broadcasting from home, even though we have an office that's 20 miles away where my small staff are. I work from home because I cannot leave a 96-year-old and 90-year-old alone. All right. So anyway, this is my home base, my home office. Yes, indeed. Okay. So let's get back to the subtyping system then. So in the Chris Payne system, what he says, the way we're going to get an intuitive pathway for you is if we give you a more specific diagnosis. If we give you a variant, we can focus on the variant so that you don't spend a lot of time taking Elmeron when it might not help you at all and lose that money and all that sorts of stuff. Because seriously, money's tight, right, my friends? I mean, it's ridiculous. Alrighty then. So let's go over the system. Chris Payne, IC researcher, Stanford University, 25 years, federally funded IC researcher. He has chaired national and international IC meetings in Washington, D.C. Lovely, lovely man. He is now in private practice at Vista Urology. So these are his 5 variants. IC subtype 1 is the one that everyone around the world agrees on. For sure, 100%. Hunner's lesions. So if you've got a bladder that has ulcers or lesions on it, you are in your own distinct group. And in fact, there has been a movement, a very credible movement now for the last 5 years to move Hunner's lesions into its own unique disease category, because people with Hunner's lesions are different than everyone else. When we biopsy a lesion, it is filled with inflammation, massive inflammation. And when we biopsy somebody without lesions, guess what? You do not have that inflammation. So what does that mean? What does inflammation mean? Inflammation means that your body, there's a war going on. It means that your body has, there's something in there that's provoking an inflammatory process. We're seeing a lot of white blood cells migrate to that area. And those tissues are very red, very irritated. I've got some pictures here. Let's see here. Yeah, here they are. Here they are. So let's show you pictures of lesions. So lesion patients tend to have the worst pain. And let's look at this one here. This is a perfect example. So you see a center area, and then you see little red arms radiating from it. And that's where you see the most inflammation. It's right in that center area. Now, lesion patients have long been the most challenging patients to treat. These are the patients who never responded to Elmeron in the first place. So the question is, why is there a lesion there? And that's part of the mystery, although we've got a couple of pretty big clues. Clue number one is that it could actually be a viral infection. We now have multiple studies from Europe showing, I keep having this thing stick up there. That's crazy. Stay. All right. um, we keep having, we've had a couple of research studies now from Europe that have found viruses in the urine of patients with IC. With Hunner's lesions, but not in patients without Hunner's lesions. Specifically, mononucleosis, the Epstein-Barr virus has been found in the bladder. The polyoma BK virus, which is a virus we all have, but that's a virus that tends to get turned on if somebody is immune compromised. And so that would help us understand why lesions can recur. Think of it as perhaps kind of like, you know how sometimes we get canker sores, which are herpes, and canker sores come back during periods of high stress? Well, maybe, just maybe, Hunner's lesions come back during periods of high stress. I'm not sure. We don't know yet. What we do know is Hunner's lesions require Hunner's lesion specific therapy. So how are we treating Hunner's lesions? We're treating them with a steroid injection. If you inject a steroid right in the middle of that lesion, the lesion calms down dramatically, or they can cauterize the lesion, or they can do Liris, L-I-R-I-S, the lidocaine pretzel. That was the first treatment in history to ever heal lesions. Unfortunately, Allergan currently has it, and they deprioritized it. They've decided, apparently, that it's not going to make them enough money. So one of the great tragedies of the last couple of months is we have learned that the Liris device is no longer being supported, which is a crime, in my opinion. I hope you will support me in my protest of that. However, we do have another therapy which can help: hyperbaric oxygen therapy. This is our latest magazine for the IC Optimist. And this magazine is our quarterly magazine that goes out 4 times a year to IC people who are members of the IC network. And in this magazine, I have a kind of an in-depth article on hyperbaric oxygen therapy. And it's fascinating. So we can talk about that again if somebody has a question about it. All right. Okay, so that's IC subtype 1, Hunner's lesions. IC subtype 2 is bladder wall driven. So this means that your bladder has been hurt in some way, because your bladder, like any other part of your body, can be injured. So the question is, what normally injures the bladder? And usually it's some sort of chemical exposure. So it's going to be chemotherapy. If you've ever had chemo can really badly irritate the bladder wall and kind of damage the bladder wall. And so patients with chemo, it's very normal for them to have some frequency urgency pain. Or if you are a big diet soda drinker or coffee drinker or green tea drinker, you got to remember that your bladder was designed for life 5,000 years ago. And they did not have a lot of acid 5,000 years ago, unless you happen to be of a descent around the equator, where there was more acid growing in the environment. For me in Norway, where my family comes from, there was very little fruit other than berries. We only had berries when they were seasonal. Today, and we had no citrus, there was no coffee, there was no green tea, there was no black tea, there was no chocolate in northern Norway, where I come from. So we can argue successfully that my body does not have a good defense against those, because we literally were not exposed to it until perhaps the last 1,000 years. So today's modern environment is very, very acid intensive. And when you're young and you have lots of estrogen, if you're a woman, and you have lots of protective coating, you might be able to get away with that acid. But when you're older and your bladder's a bit more vulnerable, the acid might actually be more irritating. And that brings up something else, and that is the quality and health of your skin. You know, the bladder is, I didn't grow up thinking I would want to be a bladder expert, in any way, shape, or form. And I don't even know if I can call myself an expert or not. But the bladder is a fascinating organ for a couple of different reasons. Number one, it's the only organ that expands. So, the bladder is like a little balloon, and as it gets fuller, it stretches. And then as it empties, it gets small again. And how those muscle fibers work is really fascinating to me. But the other thing that the bladder does is that the bladder is the only organ in the human body designed to hold toxic waste. Because urine is body waste. Urine contains ammonia and urea and all of the byproducts of the things and the chemicals that we're exposed to on a daily basis, right? So how can the bladder hold ammonia for hours at a time and not get damaged? And the answer is that your bladder is like your mouth. It is a hollow organ covered with mucus. It is a mucous membrane organ, like your vulva, if you're a woman, like your vagina, like your urethra, and like your bladder. So your bladder actually, for men and women, relies on mucus at the very top to work as a barrier. It protects your skin from whatever's in your urine. When mucus is damaged, bam, bad things can now reach the urothelial cells. And so then it's kind of like the equivalent of a mosquito bite, where you've got chemicals or venom, for lack of a better term, that's getting deep into the cells where it's not meant to be, and it provokes a mosquito bite like reaction. And then underneath the urothelium, we've got blood vessels and nerves, and we've got mast cells that can all be triggered by this chemical irritation. So this urothelial layer, this mucosal barrier is estrogen dependent. When you're young and you have lots of estrogen, guess what? You've got lots of mucus. When you're older and you have less estrogen, guess what? You have much less mucus. So this is why some women notice that, if you were in the 30s and 40s and you drank a lot of coffee every day, you were gold until maybe you were like 53. And then bam, all of a sudden, guess what? Coffee doesn't work for you anymore. It hurts. Is that interstitial cystitis? We could technically call it IC subtype 2 genitourinary syndrome of menopause. Estrogen atrophy. So the quality and health of your skin is important. It's very, very important here. All righty. If your vulva is dry, if your vagina is dry, then so is your urethra and so is your bladder, okay? The urethra is the first part of the urinary tract to react to the loss of estrogen. So what you're going to notice is urethral irritation. It will feel like a drop of urine stuck in your urethra that just won't come out. It becomes very irritated, very, very frustrating. Or you might have something that we call urine burn, where as you're peeing, your urine is burning your vulva. Now, your urine is not hot. Your urine really is not burning your vulva. What it means is that the quality and health of the skin on your vulva is not as good as it used to be. You don't have as much mucus there, so the urine is more irritating to you, okay? So genitourinary syndrome of menopause, also known as GSM, is real. And I'm going to say that at least 40% of the patients that I work with who are struggling with GSM, especially if you've had a hysterectomy, especially if you've had a young hysterectomy. If you had a hysterectomy in your 20s, by the time you're in your 30s and 40s, you are in full-blown menopause, and that skin health is something else. I had a hysterectomy 2 years ago, next month, and oh man, I aged 10 years in a year in terms of my skin just from that lost estrogen. Really disappointing. Okay. So we know you've got bladder wall symptoms. If you've got pain as your bladder fills with urine that is relieved by urination. So the fuller you get, the worse you feel. As soon as you pee, you feel better. Bam. Tells me you're bladder wall driven. And you know what? I had kind of another picture here. And let me just explain why that happens. So here is a typical injured bladder wall for for IC subtype 2. So you can see these wounds. Now imagine your bladder getting full with urine. And the urine now is going into those wounds. And it hurts and gets more and more uncomfortable, more frequency, urgency. And then as soon as you pee, bam, no longer on the wound, you feel better. Bladder wall driven. IC subtype 3 is pelvic floor driven. This is believed to be the biggest subtype. So these are the patients whose symptoms were triggered by some sort of traumatic injury to their pelvis, whether it was a car accident, falling and breaking your tailbone, if you were an athlete where you were a gymnast, and I'm talking men and women here, gymnast, ice skater, if you were riding bicycles for a long period of time, if you've had children, if you've had multiple surgeries down there. We have one research study that shows that a young boy who jams his crotch on the bar of a bicycle even once, by the time he'd be in his 30s or 40s, he might have frequency urgency from that original injury. And the same is certainly true for women. And that also helps us understand why there is a small but real subset of patients who have a history of sexual abuse. So muscles can trigger bladder symptoms. And your muscles go from front to back, left to right, and low to high. They are this beautiful basket that kind of holds all of your organs in place. But the other thing about the pelvic floor that's so interesting is really the only major muscle group that is also involved in essential bodily functions. Because here you have a urethra and a vagina and a rectum. So if your muscles are tight, guess what? It's hard to pee. It's hard to have a bowel movement. We know you've got tight muscles if you sit on the toilet or you stand in front of the toilet 5, 10, 15, 20, 30 seconds, and you cannot let your urine out. That means that you've got tight muscles in many cases. And instead of having pain before urination, you're going to have pain after urination, but you're still going to have the frequency urgency. But you're also perhaps going to have some muscle-driven sensations. You might feel like you're carrying a bowling ball around. You might feel a downward sensation or an upward pushing sensation, like somebody's pushing something inside of your body. Pelvic floor dysfunction can cause burning. In fact, whenever somebody says burning, that's the first thing I look at. Is I look at the quality and health of their muscles. So let me tell you the event which proved to me that my IC flares were muscle flares. This was probably about 10 years after I was diagnosed, and this was even before we understood the muscles. And it's important that you understand that if you go back 50 years in the literature, you will see doctors describing muscles so tight, they were like tight piano strings. They just never understood the connection, right? So this is not new. We've known that there were muscle issues for decades and decades and decades. So after things had kind of improved for me, I decided to go out one day to my local high school and just hit some tennis balls against the backboard, because I used to be a tennis player and I just loved playing tennis. And there was a guy there who said, "Hey, you want to play?" And I was like, "Sure." So I was playing with him, and because I was a college tennis player, I was a pretty good tennis player. He was frustrated. He thought he'd kick my butt, and it turned out I kind of was kicking his butt. So I was up at the net, and he decided to hit one straight at my face. And I jumped back, and I had my racket out, and I protected myself, but I felt a gush, and I thought, "Oh my God, there is a puddle underneath me." And I looked down, and there was no puddle, but I felt a couple of drops that were probably in my tennis panties, right? So for the next hour, as I finished up that match, I consciously tightened my pelvic floor muscles. And by the time I got home, I had the worst IC flare ever. And I had that flare for like 2 days. And that was because I was really tightening my muscles badly. So that was the event that proved to me that what I thought were bladder flares were actually muscle flares for me. And we know you can have different types of flares. I mean, if you can have a flare from drinking a cup of coffee, that's a bladder wall flare. But we know you can also have a flare from sex. That's a pelvic floor flare. And your ability to distinguish between the two is really important. So again, the way we distinguish is pelvic floor issues. We tend to see pain and discomfort after urination rather than before. It's very difficult to start your stream. You might have to hesitate 5, 10, 15, 20, 30 seconds before you can release your urine. A feeling of heaviness, carrying a bowling ball around in your pelvis, something that's falling out of you or something that's being pushed up inside of you, or a burning sensation or a vaginal or a rectal burning sensation. That, my friends, is usually from your pelvic floor. And let me just say here, so how do you work with pelvic floor stuff? You do muscle work. You got to do muscle work. Listen, a pill is not going to fix years of muscle dysfunction. What's going to fix years of muscle dysfunction is you working with a physical therapist, coming home, getting on your back on your living room floor and doing your exercises. You've got to retrain those muscles. Those muscles are stuck in a tension pattern. We've got to get them to relax over and over and over. Now, some of you do not like having a finger in your vagina or in your rectum. I understand that. It is weird. But you have to understand that these muscles are not accessible from the outside. They're really most accessible from the inside. And so don't freak out if they want to do internal work. In fact, it is a very, very successful. Let me just offer one other thing though. So if your doctor, now if you were to go to any major IC clinic around the world, really one of the very first things they're going to do is look at your pelvic floor. So it's a quick vaginal or rectal exam. I mean, 5 seconds, guys, super fast. If they stick their finger up there and your muscles are tight, bam, that is an essential piece of this information. That is an essential piece of your puzzle. They're going to send you to a physical therapist where you are going to have a proper pelvic floor examination. And at that pelvic floor assessment, takes about an hour. The doctor, the physical therapist is going to start from the outside. They're going to watch you walk. They're going to measure your legs, see if you've got one leg longer than the other. They're going to look for tension patterns in your core, in your legs, in your butt, in your back. If you have a lot of low back pain with your IC, look to your muscles because you have something called a psoas muscle, which starts low in your pelvis and goes up high into your back. Psoas spasms are real. I get them. If during that examination they touch something and it triggers your pain, hallelujah, baby. Woohoo! They found it. This is big. This is perfect. This is exactly what we want. Do not be afraid of that pain. If you have an assessment and they can touch stuff and it triggers discomfort, that is incredible news. That is the best news ever because they found it. They found it. They had their fingers on it. So now what I want you to do is I want you to ask them, hey, what is that muscle? Have them name it. Is it your levator muscle? Is it your, whatever muscle it is, have them name it so that you walk out with the names of the muscles that are screwed up so that you can not only heed your physical therapist's advice, but you can also maybe go over to YouTube and look at how other physical therapists work on it. All right. So, and I'm just going to say here, I know that there are some of you who have been a victim of sexual abuse, and the thought of anybody doing any internal work is impossible. It's okay. In fact, I just read a wonderful article by a physical therapist about that. Tell them that, and they will work instead externally until you get comfortable with them. And you may get to that point where you might be able to do a little bit of internal work. You may not, but listen, the physical therapists out there are lovely people. They're kind. They've done extra training so that they can help you. They really, really sincerely do want to help you, and they will work with you, okay? Hugs to you. Hugs, hugs, hugs to you. Okay, let's go to the next subtype. I see subtype 4, pudendal neuralgia. This, my friends, is a nerve injury. So these are the patients whose symptoms are electrical in nature, burning in nature. If you've got pain when you bend over suddenly or pain that shoots down your legs, and actually, hold on a sec. Svetlana says, can IC cause muscle spasms in the Kegel area? IC subtype 3 pelvic floor dysfunction, yes, can cause muscles in the Kegel area. That is exactly pelvic floor dysfunction. Okay, Svetlana? Exactly. So you would, that's it. That's it exactly. Let me do this, and then I need to explain the chicken versus the egg dilemma. Okay, but so let's talk about this nerve thing again. So I see subtype 4 pudendal neuralgia. This means that you have a nerve in your pelvis that's been compromised. And your symptoms tend to be positional in nature. You're fine when you stand, but when you sit down, it hurts. When you bend over, it hurts. When you squat down, it hurts. And it tends to be an electrical searing pain like sciatica that shoots down your leg or goes up your back. If you've got pudendal neuralgia, generally what that means is that you have muscles so tight they're squeezing nerves. So what's the therapy? The therapy is getting to the root core of the problem, which is going to be really, really tight muscles combined perhaps with nerve blocks. One of the conditions of pudendal neuralgia is PGAD, persistent genital arousal disorder. If you ever go through a period where you've got this very weird arousal sensation that's painful, that's usually the pudendal nerve that has been injured, traumatized, or continuously irritated by tight pelvic floor muscles. Alrighty? And then I see subtype 4, central sensitization. This is a subtype that is inherited, that tends to be inherited. So this is my subtype because IC goes back in my family for 3 generations, if not longer. And what it means is that we have nerves throughout our body that are easier to turn on. So we tend to have very sensitive skin. We tend to have a sensitive stomach. We tend to have a sensitive gut. We tend to have a sensitive bladder. We tend to have a sensitive vulva. We tend to have a sensitive rectum. We tend to have irritable bowel. We tend to have vulvodynia, things like that. And so in this case, this is often the gift of our ancestors. And it kind of makes sense because 5, 10, 15, 20,000 years ago, you needed sensitive people in your tribe to help you find food. Hello, we have a wicked sense of smell. We can smell things that other people cannot smell, and smells really drive us crazy. Unfortunately, again, today's modern society, modern environment is very rough on our nervous system, between caffeine and foods that are neurostimulatory to all the chemicals in our environment. Our nervous system tends to be pretty traumatized. So you can learn more about central sensitization on our website. It's not a disease process. It tends to be inherited, although nerves can be sensitive and injured after major accidents too. Alrighty. Now I want to talk a little bit about the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? The odds are both are involved, but one is always driving the other, right? So for some people, so here's your bladder and here's your pelvic floor. Let's say you're a cancer patient going through chemo. So the chemo is really irritating your bladder and your bladder is throbbing. And because your bladder is in pain, your muscles get very tight to protect you. We call that the guarding reflex. So for this patient, our treatment priority is to calm that irritated bladder. We know that if we can stop the bladder from spasming, the muscles will release, right? So that's the classic diet patient, bladder coating patient, plenty of water patient, even Elmeron supplement patient. We can call, or genitourinary syndrome. If we can calm that bladder and get it to stop throbbing, the muscle should be released. But that's the smaller of the two. I can't say most, but I'm going to say a significant majority of patients, it's exactly the opposite. They have a normal, healthy bladder, and then bam, they fall, or they have a baby, and their muscles are injured in the trauma, and they get tight. So now you've got tight muscles squeezing your bladder. Now you have no clue you have a muscle injury, none at all. Your first symptom is frequency urgency. What do? You call the doctor, say, I think I have a bladder infection. They give you antibiotics. They don't work. You call back the doctor. They give you overactive bladder medications. They don't work. You call back the doctor. The doctor says, maybe you have interstitial cystitis. They throw Elmer at you. That doesn't work, and your symptoms continue to get worse over time. For this patient, no bladder treatment is going to work because their fundamental problem, look at how my fingers are turning white, right? That's what happens when muscles are tight. When muscles are tight, it restricts blood flow. So for this patient, our therapeutic priority is to restore blood flow. How do we do that? Physical therapy, releasing the muscles. When we release the muscles, the bladder can now get the circulation it needs to be healthy. So one is always driving the other. And if you go back to when your symptoms began, let's see if I can give you a couple of good examples. Okay, high school football player in the prime of his career, right? Prime of his career, develops frequency urgency all of a sudden. No clue why. Diagnosed with prostatitis, follows the prostate treatment paradigm for 4 years. He's 24 years old, not getting any better. Calls me, we start talking, and I go, so what happened when this started? He goes, oh, I went skiing. I fell off the ski lift. You fell off the ski lift? Yeah. Badly? He goes, yeah, right on my tailbone. No one had asked him about that. He goes to the pelvic floor physical therapist. What do they find? Massive pelvic floor dysfunction. Man, we could tell story after story after story of patients like that where there was some sort of traumatic event, whether it is falling on your tailbone, showing off, doing a Tom Cruise impersonation, sliding on. I had one gentleman who was sliding in his socks on his wooden floor, fell down at the top of his wooden stairs, and then he went butt first down the stairs, and literally the next day had frequency urgency. Or you take that gymnast who has fallen multiple times, or that ice skater who has fallen multiple times. So you just got to remember this. If you're not getting better with bladder therapies, if you're getting worse over time, what the American Urology Association says, take a step back and let's revisit this diagnosis. Let's make sure we know what we're treating. If you were diagnosed 20 years ago, 25 years ago, and you've been on Elmeron for 20 years, it's time to take a step back. Let's get a proper diagnostic workup now that we know what we're dealing with, right? So using the Chris Payne subtyping system, what does it give us? It gives us a treatment pathway. So I'm IC subtype 5, IC subtype 3. So as subtype 5 central sensitization, it is my responsibility to clean up my environment and to keep my nerves fairly calm. I do not drink coffee. I very rarely drink coffee. I don't do anything neurostimulatory. I've left the chemicals out of my home, and I'm doing everything I can to be calming and soothing to this more sensitive nervous system. But ultimately, I have a pelvic floor injury on my left side that I have had. I actually remember injuring it. I was 21 playing tennis on the tennis court. I remember it. I remember the snap. I remember bending over. I remember stretching at the net. And now when I work with a physical therapist, I'm now working with a sports physical therapist. He's finally the one who actually found the injury, which was a torn piriformis muscle. Okay? So those are the subtypes, my friends. Those are the subtypes. Now, let me just offer, I was reading through the report from the ESSIC, the European Society for the Study of IC, had a meeting in December. And Phil Hanno, who is the chairman of our own American Urology Association IC committee, suggested that we not rush into subtyping. And I agree with him. I mean, we all understand that Hunner's lesions are distinct. There's no doubt about that. Man, if you got Hunner's lesions, you belonged in your own unique group. And in fact, I built a website for you, hunnerslesions.org. What we're probably going to see in the next 5 years is that split off into its own unique disease. And then the rest of us are going to be in the bladder pain, pelvic pain syndrome category. So he says, let's not rush to judgment. Let's not go too soon. I agree with that. Chris Payne agrees with that. We think that there are many more subtypes. I think that there's an autoimmune subtype for some patients. I also think that there's a hormone dysfunction for some patients. You know, at our last meeting, I did a drop-in meeting on Wednesday. I had two patients come in with very, very low testosterone. One was a man and one was a woman. And they asked me, can low testosterone trigger IC symptoms? And I didn't know. And so I emailed my medical board and Rob Moldwin, and it's totally the wrong time to mail them because they're all getting ready for the big conference in a week. But he did get back to me, and let me read you what he said. Where is it? He says, ridiculously overloaded with work. He says, my position on this is very conservative. I think that we should keep to the clear medically indicated uses for hormones. I think that it's certainly possible that there may be some benefit related to IC symptoms, but this is not something that has been well studied. So if you were here on Wednesday when I did that meeting, that is my answer to that, is it's just not well studied. Let's see here. I have more to say about the conference, the convention, but I want to wait a week before it comes out. There's one really thing that's really pissed me off about a poster at AUA on pain and opiate use. And I raised that to the attention of my medical board, and I think they agree with me. And for those of you who know, the FDA did finally issue a safety alert about forcing chronic pain patients off of opiates. That there are far more consequences to that, and it is harming people. So that's a whole nother meeting. All right. So let's take some questions here. Now, guys, if you're on Facebook, please know that Facebook will not allow me to scroll back. And I saw a couple of really good questions, but let me just see how far it'll let me go back. We are simulcasting on Facebook and YouTube. So if I'm looking up, I'm looking at Facebook. If I'm looking down, I'm looking at YouTube. Be moving over to Twitch very soon, and even Discord. I think we're going to have a voice support group meeting again. We did that. The IC Network, we had a chat room for many, many years where people dropped in and could talk to each other. And I think we'll be bringing that back. There are just some legalities about that. All the health chat rooms got shut down about 15 years ago after America Online lost a big lawsuit. And so when we do it, I'm going to have to be very careful with it. But anyway. So hold on a sec. Let's see here. I love the way you guys support each other. You are awesome. Eileen says, I have burning after I urinate maybe 30 seconds. After I finish, it will last about 2 minutes. Is that considered pelvic floor? Hun, it depends on where the burning is. If the burning is external on your skin, then that's probably estrogen atrophy. If the burning is internal in your vagina, in your pelvis, then yeah, it's probably a pelvic floor spasm. Rebecca says, I have burning with my chronic UTI. I'm going to get checked out by a pelvic floor specialist in May to see if they can help easing the burning symptoms. I know it won't get rid of my infection though. So remember that muscles that are working hard are muscles that build up lactic acid. So if you were to go run around the block, you know that your leg muscles would start burning, right? They would start burning because they're working. Well, your pelvic floor muscles do exactly the same thing. If they're working hard, they're burning. They are burning. And so there you go. And for those of you who are wondering about chronic infection is definitely a subtype of bladder wall driven. And for those circumstances where if you think that you've got a chronic infection, you should definitely have a next generation urine test. definitely, and that will tell us, if you come to bladderhealth.org, you can order these on your own in 25 states, bladderhealth.org. It will tell us your good bacteria, your bad bacteria, and any fungal infections, because fungal infections are playing a much bigger role than we realize. And in fact, there was another research study that I was going through, I think on Friday, where they were looking at the biome of IC patients to see if is there a different bacteriological difference between non-IC patients and IC patients. Our own federal MAP research study found a difference in biome in the bowel. But this study, which was done at Loyola, I think, Loyola Marymount in Chicago, did not find a significant difference in bacterial infection between IC patients and non-IC patients. But their last line was something about, but they didn't look at fungus. It's like, hello, you just missed half of the puzzle here, because if there's any population of patients overexposed to antibiotics, it's going to be the urinary patient. And again, our own National Institutes of Health have found that many IC patients having flares actually have candida fungal infections. And a typical urine test will not identify that fungal test, but you know what? This will look for anaerobic bacteria, aerobic bacteria, and fungal infections. If you were to do all those separately, it would be like $600, $800. This test will do it all for $199. Now, granted, a lot of local doctors don't know about this, because this is very cutting edge research. All the researchers have been using it for 5 to 10 years, but it has not disseminated down to the local clinic yet. So it is the local clinic where you will be, and you go, hey, can I have an next-gen test? They're going to go, what's that? Like my local Kaiser urologist said, what's that? And it's like, oh, it's a DNA test. They're like, well, let's just do a urine test. And it's like, dude, we know typical urine tests do not identify more than 90% of the bacteria and certainly fungi that can be in your bladder. Old urine tests are old and outdated. We have new methods for testing your urine. It is a DNA test. It is a next-gen test. And this is what is identifying those chronic infections. It's exciting, right? It's exciting. I'm a geek, guys. I like stuff like that. But more importantly, I want you to have answers. Answers. Hey, let me take a moment, and I need to make sure that we thank our sponsor, woohoo, Pre-Leaf. If you have been around for a while, you know that Pre-Leaf has been available for IC patients for the last almost 30 years. It is an acid-reducing supplement. So if you've ever on Easter, you need to go to grandma's house for your Easter dinner, and they are going to serve pasta, and you can't tolerate the acid, what you can do is you can take a Pre-Leaf or two, and that will reduce the acid in the food so that you can eat more. So Pre-Leaf is a staple in the IC diet. If you are traveling, if you feel like you're going to be exposed to a food that you really shouldn't eat, taking a 1 or 2 Pre-Leaf is a great thing to do. I have been working with this company since I founded the IC Network 25 years ago, and there's a new company now, DSC Healthcare Solutions, that has it. They're absolutely wonderful. And so check this out. I'm going to give you one warning though. Listen, I am not a more is better person. There are some people who eat this like candy. You should not eat this like candy. It is a calcium-based supplement. And if you throw a lot of calcium in your body, you could start throwing kidney stones. So really, this is just about doing it appropriately. 1 or 2 pills before you eat. This is not candy. More is not better. And that is true for all of the supplements. Some of you out there, you get so desperate, and believe me, I completely understand. You'll double or triple stuff. That's not a good idea. Because you got to remember, all those metabolites are going to end up in your urine anyway. And that could be more irritating. That's why we don't want you to do a multivitamin. When you do a vitamin, what happens? Your urine turns bright yellow within an hour because your body can't use all that vitamin, period. If you're one of those people, you think you need to have vitamins to be healthy, you are wrong. We did not have vitamins 100 years ago. Vitamins are a man-made construct because we started taking so many vitamins out of food. People were getting sick back in the early 1900s. They started fortifying breads to put the vitamins in. It became an industry. The problem is that it is physiologically impossible for the human body to absorb all of those vitamins. You might get 2% of it absorbed. The rest you pee out. So again, I'm not a more is better person. I'm a less is more. That's my personal approach. Lisa says, I've been having some good luck with marshmallow tea. Helps with the burning a lot. And so marshmallow tea certainly been around for a long time. And corn silk, I think corn silk's another one. I'm not an herbal tea person myself. The challenge with marshmallow tea is first, it helps about half of the people and it hurts about half of the people. So you got to try a small amount and see how you do first, but it's worth a shot. In terms of teas, chamomile herbal tea, peppermint herbal tea, or rooibos tea. This is a pumpkin spice rooibos tea that we have on the IC network. I could drink this all day and it would never hurt me. Amanda. Let's see. So Amanda has kidney stones. She has acidic urine. I'm allergic to certain antibiotics, so I get very sick, right? Plus you have endometriosis and fibroids, so I'm on seasonic birth control to have those. So that brings up another really interesting point here is, okay, guys, so again, our magazine, this is our latest issue of our magazine. Members, you can download this on your member page right now, or you should have gotten this by mail if you get it by mail. Last week, 2 weeks ago, I sent out, they were our freebies in our magazine. So about 15 of you got copies of this. The theme of this magazine are all the weird, underestimated conditions that we know can trigger bladder symptoms, of which fibroids is one. And so let's look at this for a moment. This is an amazing picture. So look, a fibroid is a benign tumor. It can be in the uterine wall. It can be protruding into the uterine cavity. And so some fibroids are so big, they actually prevent a baby from growing if you're pregnant. Or look at this, they can come outside. They can grow on the outer wall of the uterus. The biggest fibroid, I think, in history was 140 pounds. But last year, somebody had one that was 60 or 70 pounds. It's like a balloon. A pumpkin. If you've got a giant mass pushing on your bladder, you know what? You're going to have bladder symptoms, my friends. You're going to have bladder symptoms. And what we know is that, let's see, what was the statistic here? There was a fascinating research study. I think, okay, don't quote me on that. I can quote half of it. I think that they said something like 85% of women with fibroids have urinary symptoms. And when those fibroids were removed, 65% of them were cured of their urinary symptoms. Cured. So if you've got fibroids, it would be perfectly reasonable to want to do something about those fibroids, right? Right. Same thing with endometriosis. The other thing that this magazine covers are, again, I have this great reprint of an article by Susanna Weiss. I was really happy to see this on another website, and I asked her if we could reprint it and paid her for it because it's absolutely worth it. How 10 women got to the root of their bladder pain. Hannah, age 23, her bladder pain was pelvic floor dysfunction. Tabitha, age 24, her bladder pain was endometriosis. Megan, age 45, leaky gut. Laura, age 51, candida. Dana, age 53, Lyme disease. Another patient with food intolerance, another patient with chemical sensitivities, another one with autoimmune disease, another one with chronic UTI, and another one with gut dysbiosis, probably from the overuse of antibiotics. So, again, you are an anatomical mystery to be solved. We've got a lot of work to do to rule out stuff that could potentially be triggering your symptoms. If you walk into a doctor's office and a doctor says, hey, you've got IC, you're going to say, okay, what variant? Can we please look at the many things that can contribute to bladder symptoms? If you've got super painful periods, if you bleed a lot, we got to be looking at fibroids and endometriosis, my friends. Okay, just like if you're a man and you have sharp shooting pain and or a lot of rectal pain, we got to be looking at your pelvic floor, right? So we got this. It's more work for you, but it is productive, meaningful work. If you have a next gen test and it says you have no pathological infection and no fungal infection, you can walk away now. You don't need to do that anymore. You don't need to take antibiotics anymore. It's time to look at other things like your muscles, et cetera, et cetera. Sam, is it possible to have more than one form of IC? Is it possible to have more than one subtype? Yes. Yeah, absolutely. IC subtype 5, subtype 3. Kristen said she had a 30-minute low-pressure hydrodistension with Botox injections into the pelvic floor, and it made an amazing difference. That's awesome. So Botox would also stop that incredibly tight pelvic floor situation. Rebecca says, I'm very nervous about seeing my pelvic floor specialist. She will be sticking her fingers inside me. Hun, she's going to stick one finger inside of you with a glove, okay? And you worry about what lube she'll be using. She'll be using KY. They normally just use something very simple like KY, but if you have another lubricant that you would prefer that she use, bring it. But don't worry about it at all. It's so important to do. And it would the information just from that one first visit is so meaningful and so important. It will help us solve the mystery of your pelvic pain. Allison said she's subtype 2 bladder wall, but she did just start pelvic floor therapy because she was having some tightness and it is helping her sleep better. Awesome. Glad to hear it. Veronica says, I've had a hydrodistension to my bladder 6 months ago, and I'm still having pain from that procedure. I truly believe that it made it worse. I've never been the same. I don't recommend the procedure to anybody. I regret the day that it was done. Veronica, your experience is very, very common, especially before the release of the American Urology Association guidelines. It sounds like you had a doctor who did a high pressure, long duration hydrodistension. I mean, think about it. Here, hold on a sec. My dress is stuck in my chair. Okay. Okay, so think about it. What is this? Stay. Okay. There we go. So, in the old days, my dress keeps getting stuck underneath my chair. In the old days, when I say old days, prior to 2011, the perception was, so here's your bladder, and let's just say you have a small bladder capacity, or the assumption is you have a small bladder capacity. So what urologists used to do is fill your bladder with water, right? And they would get it to its natural point. But then because you were asleep in the operating room, they stretch it. And so the assumption is that it gives you more bladder capacity. And when patients had a high pressure, long duration test, which means they really stretch it under high pressure and they leave it in for a long period of time, what happens anytime you stretch a hollow organ, it can be a bit damaging. In fact, bladders can rupture. Bladders have ruptured after hydrodistensions. In the new American Urology Association guidelines that were released in 2011, they begged and pleaded with doctors to not do that anymore. Our goal here now is to not traumatize the bladder. So instead of going woo, they now go woo. Just fill the bladder up just enough so that they can get a good look in it, do whatever they need to do, like inject Botox or whatever, and then you're done. I had a low pressure, short duration one 2 years ago, and it was fine. So, Veronica, I'd be very, very interested to get your notes from your doctor to find out what the hydrodistension that he did, because it sounds like he did a big one. But the one, and you need to tell him that you're still having pain from that. But the one thing you can count on is that healing is always happening. Any damage that procedure did to your bladder is healed. The question now, though, is are you having, because your bladder was screaming, are your pelvic floor muscles tight? And the odds are they probably are. So you need to get back to that doctor. Let's revisit that diagnosis. Check to see if you've got muscles tight, because that guarding reflex is real. That's how the human body is wired. It's wired to guard you. Guys, seriously, if a doctor wants to do a hydrodistension now for you, it needs to be low pressure, short duration. And if they say no, then I would not have it done, because that is the American Urology Association guidelines. Period. Over. If they don't know about the guidelines, then you need to tell them to go to auanet.org, go to the American Urology Association and read them, because we now acknowledge damage happens with high pressure distensions. We want to go low pressure to reduce trauma. Kim asks, once a bladder has been damaged due to trauma, can it ever heal? Yes. Healing is always happening. The challenge is the bladder has the largest single cells in the human body, okay? So these urothelial cells, we call them umbrella cells. These are the largest single cells in the human body. When one of these is damaged, there is a little tiny stem cell. So imagine an extra large pizza, which is the cell, and then underneath it, one single green pea, that is the stem cell. So there's a little tiny stem cell that will take at least 2 weeks to grow in and change shape to fill out this cell. So healing in the bladder is slow. But the problem is we tend to get in the way of healing. How do we do that? Acid. A bad diet. If you pour acid on that growing cell, you're probably going to kill it. And that's what Dr. Anthony Schaefer said at a National Institutes of Health IC meeting years ago that I went to. Is he explained that the stem cells that are trying to repair these cells are very, very fragile. And if you have one soda or one cup of coffee or one cup of green tea, you're probably going to kill that entire generation of cells. So you set yourself back 2 weeks. So every cup of coffee you drink sets you back 2 weeks of healing at a minimum. And that's why people who drink 1 cup of coffee a day are often in the worst shape, because they don't understand they're interfering with the healing process. Do you think dry needling can be helpful in treating IC? No, but dry needling can be helpful for the treatment of pelvic floor dysfunction. So guys, listen, I don't want you to keep using IC as a generic term. That's a little tricky. That's going to make it harder for you as you work with doctors. Will dry needling help tight pelvic floor muscles? Absolutely. Absolutely. If you've got trigger points, go for it, my dear. Go for it. Svetlana says she thinks she has 2 subtypes, bladder burning after certain drinks, and that you have a painful spasm in the Kegel area that feels burning inside, like golf ball stuck inside. Yeah, hun. Textbook explanation for what type pelvic floor muscles feel like. Feeling like you've got a foreign object stuck inside your body or somebody's shoving something up. For me, it felt like somebody was shoving a wide funnel up my urethra or up my vagina. Or after my hysterectomy, it felt like there was a fist up my vagina that was pulling downwards. That upward, downward heaviness, all muscle symptoms. Karen says she fractured her pelvis in 4 places, never been right since. So your bony structures are probably healed, but the odds are you sustained muscle injuries at the same time that were never addressed, Karen. You're going to be a fun patient to work with, but you're going to be a frustrating patient to work with, because if that happened some time ago, then we're dealing with long-term dysfunction here. But that doesn't mean that muscles don't respond to therapy. Muscles can respond beautifully to therapy. Jody says, were you able to find out info on the testosterone? Yeah, I just said it about 20 minutes ago, and the answer is we don't have an answer, and the doctors are very reluctant to do testosterone therapy for IC. Karen says, bioidentical hormones made by compounding pharmacists for hormones help IC? No, let's be clear. Bioidentical hormones made by compounding pharmacists help your skin produce mucus. Quality and health of your skin. Can Climax trigger an IC flare? Absolutely, because it's a pelvic floor spasm. Many women, when you have sex, you don't have any discomfort at all during the act itself. It's afterwards that you get it, because that's when you have pelvic floor spasms for about 24 hours. Catherine, what makes your stomach swell and get hard during a flare? Usually it's just inflammation. We call it the IC belly. It comes and goes. I have to say, I notice that for me, my stomach swells if I eat anything super sweet or with white bread, which I did this morning with our Easter thing. As I was getting dressed for this, I looked at my stomach and was like, holy hell, where'd this come from? It's like, woo, wait, that wasn't there yesterday. And it tends to be it comes and goes. Pamela, I'm having kidney stones removed early in May. Hopefully blood will clear up. Awesome. I really hope so. Kidney stones are tricky because kidney stones are very sharp and they're covered with bacteria. And so it'll be good for them to get them out of you. Brittany just started seeing a PT who says, yeah, she has pelvic floor. He suggested dry needling. Do you think it would be helpful? Hell yeah, I'd do it. I think so. Ask for risks. Got to talk to him about the pros and cons so that you're educated and informed. But dry needling can be very helpful. All right, I'm going to come down to YouTube now. I'm sorry, YouTube. I love you guys on YouTube. Sorry about that. Let's see here. Hold on a sec. Karen is hosting Easter dinner. She just prepped a special plate of food for herself. It's all good, though, because I'm glad to do what I can do. Yeah. I don't know if I'm going to get to our family holiday. I don't know how my dad's feeling because it's 20 miles away. I can't leave him if he's not feeling well. EAO on YouTube says, do you have any advice for IC patients considering bladder removal? Hell yeah. Number one, you better have exhausted your diagnostic workups. Listen, bladder removal is very rare and only in situations where the bladder is badly, badly damaged and shrunken. So if your bladder is down to the size of a walnut, instead of being the size of an apple or a pear or grapefruit or whatever, there are moments when bladder removal is important. And we have a bladder removal board over on our website in the ICN support forum. One of our best volunteers over there runs that. And, there are times in a very, very, very small subset of IC patients that bladder removal is reasonable. I'll tell you one story of a patient that I know. When she was a young girl, 14 or so, she was in a bad car accident and had symptoms afterwards and had very, very severe symptoms for about 10 years to the point that she was inconsolable. And when I talked to her the first time, I would tell you that she was in terrible shape, very, very emotional. And, even to the point where even I was like, what is this? They finally did exploratory surgery on her and they found that her bladder was ruptured and it had been ruptured for a decade from the car accident. And the damage was so profound, they had no choice. They had to remove her bladder. And she's actually on Facebook. So there are moments when bladder removal might happen, but I want you to have a full diagnostic workup too. I want to know, listen, bladder removal will not fix pelvic floor. It will not fix pudendal neuralgia. It will not fix tight pelvic floor muscles. It will make pelvic floor muscles worse. So we really got to know here. So EAO, listen, if you want to call me this week, I'd be happy to talk with you and kind of let's see if we can, you know, dot our I's and cross our T's and go through kind of a more extensive workup. Again, I want to look at some of these other conditions. I want to see if you've got fibroids, endo, fungal infection, anything at all like that first, okay? Donna says, why can't the urology community come to an agreement about subtypes? Will they ever? Early on, when I first got involved 25 years ago and started going to these meetings, the competition was fierce, fierce. You got to understand, doctors and researchers are fighting for research money, and they also have fairly large egos. And whoever is the top dog at the time is a target. So the top dog for many years was Lowell Parsons, who invented Elmeron. And you being at a meeting where he was the speaker and you're sitting with the other kind of lesser urologists at the time, they're jealous, envious, frustrated. They might disagree with them. So rather than having really good constructive discussions back then, it was really pot shot after pot shot after pot shot. It was not a nice environment. And everybody has something to add. Dr. Parsons is brilliant. And yet Elmeron is flawed now, but he has done amazing things for IC awareness and developed the PUF questionnaire, all sorts of things. So he has a very important role in this community, just like Chris Payne has a role in this community and Phil Hanno has a role in this community. And Dr. Nordling and Dr. Fall in Sweden. The question is will they sit down and talk well with each other? And 20 years ago, that answer was a firm no. There was tremendous competition and tremendous arrogance. I personally listened to an American doctor tell a European doctor that he would always fail and that he needed to believe what the Americans believed. And that's exactly why the European Society formed, is they were so frustrated with the Americans, they created their own IC society. And then the Japanese created their own society. And thankfully, those competition times are done now. And I think people are more sincerely working together. But again, there's still competition. There's still who's going to come up with the right system. Some doctors are very focused on evidence-based medicine. Others are very focused on what do we have as a tool that we can help a patient today. Screw the ethics. I have a patient here with tight muscles. I'm going to treat her or him. So they have different focuses. But it's getting there. They just want research to back it up. And I think we're too impatient for that research. And I think appropriately so. It's like, come on, guys. Did you just please test my muscle? I don't care if there's a research study. Are my muscles tight? Okay, good. I'm going to go get pelvic floor work. And we have research to back that up. But some of the other stuff we don't. Okay, sorry. Does Dr. Payne take insurance? No, he does not. He's a cash. Many clinics now are cash and carry. The reason why they go into private practice is that so they don't have to deal with having 50 staff members who handle all the billing. So I believe that he's a cash and carry clinic now. Elise says, I'm in Norway. Hello, Norway. I still have cousins in Norway, in Drammen. I've had terrible pain for 1.5 years, had a cystoscopy done at the hospital, but they didn't want to take a biopsy even though I asked. I did not have lesions, they said. Well, that's good, hon. If you did not have lesions, there was no reason for them to do a biopsy. But on ultrasound 9 months later, your bladder wall was thickened from scarring. I get Uracyst every week for 6 months, but it doesn't help. I went into my menopause last year, and you are so correct. I can't drink a soda anymore at all. What a surprise to hear your family is from Norway. We are sisters. Family name is Larson and Johansson and Henriksen. All right. So, Elise, getting back to your bladder wall was thickened and scarring. That really makes me think about chronic infection, hon. I mean, I think it'd be really interesting for you to have a next generation test to see if there's anything related, because unless they didn't know how to do a cystoscopy, unless they were not experienced at diagnosing lesions, we should be able to take what they say at face value. They said you did not have lesions. But the fact that your bladder wall has thickened in 9 months is disturbing to me. That means I think that either your bladder wall is profoundly irritated, and we've got just a irritation process happening, or I have to wonder, chronic infection. Is there a chance you have a fungal infection? This next generation urine test is available internationally now. You can go to their website and you can call them and order it in different countries. And so you might be able to get this done. And I think that would be a very interesting piece of your puzzle. We've got to figure it out. Guys, I always say to patients, please don't walk into a clinic and say you've got IC. Don't let that be the first thing out of your mouth, because you fall down the rabbit hole of IC and their belief structure. Instead, I want you to walk in and say, all right, I have a thickened bladder wall with pain. Can you please help me understand why that could be happening? Because a thickening bladder wall is not a symptom of IC. But it might happen to some IC patients. Is it possible to have IC if the bladder wall is not scarred or doesn't have lesions? Absolutely, hon. You're just a subtype. So if you don't have lesions, that's great. You're not IC subtype 100 lesions. You might not even be IC subtype 2 bladder wall driven. The odds are you're IC subtype 3 pelvic floor injury, or IC subtype 4, IC subtype 5 central sensitization. So my bladder is perfectly normal. You look at my bladder, there's absolutely nothing wrong with it. I had one little tiny red spot on it. Because my subtype is not really with my bladder. My subtype is really with my pelvic floor. Carol says she gets contractions during urination. Hun, that's a bladder wall spasm. So if you ever have a sharp shooting pain that kind of goes up your spine and down your legs while you're peeing, that, my friend, is a smooth muscle bladder wall spasm. You got two different types of muscle. Your bladder wall is composed of smooth muscle. Your pelvic floor is composed of skeletal or striated muscle. They're different types of muscle. If you're having spasms during urination, especially as the last couple of drops are coming out, that really points to a bladder spasm. Now, thankfully, we've got wonderful medications which can stop bladder spasms in 20 to 30 minutes, known as oxybutynin or ditropan. The only time I've had bladder spasms in the last 25 years was when I had a UTI that I thought was a flare for 6 weeks, and it got really, really bad. And that's when I started having bladder spasms. So the bladder wall spasms, when it's profoundly irritated, it kind of quivers, so if you've got a wounded bladder and you're drinking beer and you're drinking coffee over and over and over, the bladder just gets to the point where it just starts to kind of shake and quiver. It's like really trying to get your attention and say, help me, help me, help me. And that's the way I interpret a bladder spasm. So you need to take a step back. Let's make sure you don't have infection, but also make sure you're really protecting your bladder with your diet, okay? And not irritating it and provoking it. Marcia says, any advice on pain management during a flare? When my belly starts to burn, it scares me because I don't know how long it's going to last. It incites panic with me. Fighting a flare is like fighting a fire. You want to catch it when it's young. You want to catch it when it's early. If you let it go out of control, it's going to be a much harder flare to treat. Some of you out there, you wait and wait and wait until you're crying before you do stuff. And that's a total mistake. You've got to act early and aggressively. So how do we start? The first thing we do is we try to figure out what type of flare you're having. And so this is the question I ask patients is, when is your flare the worst? Before you pee, while you're peeing, or after you're done peeing? If your flare is worse before you pee, that's a bladder wall flare. So you're going to be doing things that will calm and soothe your bladder. You're going to be drinking water to dilute your urine, maybe using some pre-leaf to acidify your urine. You might be using azo, bladder pain relief tablets to kind of numb your bladder wall, follow the diet, yada, yada, yada. If your pain is worse while you're peeing, that is really suggestive more of a UTI and or estrogen atrophy. So normally what you would do, if you've got a burning urethra while you're peeing, let's see, where is it? Oh, I already put it down. These are really useful to have on file, at home. Azo urinary test strips. So if you've got burning, strong burning while you're peeing in your urethra, man, the first thing we think is infection. So you want to test your urine, right? I mean, you just open it up, pull out the wand and pee on it. Okay, just pee on it. Come on, it'll take you 5 seconds. And what, this is like $10 for 3 pills. I mean, this is worth it. And so here is the little thing you pee on. And there are 2 strips, there are 2 pads at the top. The top one tests for leukocytes, the bottom one tests for nitrites. If both pads turn purple, you got infection. You got to get yourself to the doctor, go have a urine test and get yourself on antibiotics. If they are negative, if they stay clear, then you're probably having a flare. All right. If you get a little pink on the top but nothing on the bottom, that's still a flare. It's normal to have some leukocytes in your urine when you have IC. It's the nitrites that are produced only by bacteria. If the bottom pad turns color, you got infection. If the bottom pad stays white, then you don't have infection. All right. So that's something that we would be looking at. And then, of course, estrogen atrophy. If you're of an age and you're starting to get dry skin, your urethra is going to burn. Okay. So that's when we use an estrogen cream to give that skin some of the estrogen that it needs to produce mucus. And last but not least, if you have pain after you're done urinating, we're really looking at your muscles instead. So rather than doing the pre-leaf, what you're going to be doing is muscle relaxation. I want you to take a hot shower, take a hot bath, use a heating pad, use a muscle relaxant, do your stretches, things like that. Guys, if you go on over to the IC Network website, ic-network.com, and you sign up for our free newsletter, you will get our 40-page flare management guide. Thousands of patients are using it very, very successfully, more than thousands. I mean, I've had it for, I think I was first one to ever write a flare guide, and I think this is my second edition, 10 years. Hundreds of thousands of patients have read it and used it. And so give it a shot. It gives you an hour by hour rescue plan for the types you have. And I'll be rewriting this again soon, updating it. Hello, Carol from South Africa. Very, very nice to meet you. I've worked with several patients in South Africa, to be quite honest. I wish I had a doctor. I think I might have one doctor in South Africa, but I have to dig to find it. I'm sorry to say. All right, let's go back to Facebook. Regina says, I know that when I have candida, my IC pain is so much worse. Oh, hell yeah. I'm telling you, I had a 2-year-long drug-resistant candida infection about 15 years ago after I did the Fugazzotto protocol for IC, which we now know is flawed, but hello, we were all kind of desperate back then, or maybe 20 years ago. Augmentin for 6 months. What a royal mistake that was. And I ended up with a drug-resistant Candida glabrata infection. It took us 2 years to kill. And I will tell you, having Candida in your urine is so much worse than a regular IC flare. The pain was insane. It's amazing. So fungal infections happen in the bladder. Veronica says she can't drink chamomile or peppermint tea. It gives you pain. Can't drink anything except milk and water for 6 months. Well, girl, then that's what you need to do. You need to drink the water. Because really, the human body's designed for water. Human body's really not even designed for milk once we're an adult. And that's what if that's what your body's thriving on, then keep on the water for now. And let's really give that bladder an opportunity to heal. But hon, listen, you're always welcome to give me a phone call next week. And I'd be happy to work with you a little bit and see if we can figure this out a little bit more. Erin, she has her first cystoscopy with hydrodistension tomorrow. Is it normal for them to not find anything? It's great news. Hey, girl, listen. If they do a cysto and your bladder's normal, hallelujah, fantastic news. You don't have to do any bladder therapies. What we're going to be doing instead is focusing on pelvic floor. But listen, since you're having it tomorrow, let me give you a couple of things that I want you to be kind of cognizant of and wary of. When you get to the hospital and they check you in, you're going to have an opportunity to talk with your doctor and the anesthesiologist before you go in. With the anesthesiologist, you want to have a discussion about the type of anesthesia that's used. This is really a twilight procedure. Versed is your friend. I always tell doctors, if I have no memory of it, you're gold. Whether it's a colonoscopy or anything or dental work, seriously, give me Versed. If I have no memory of it, that is a great success in my book. So they will often use a little bit of Versed. But from an anesthetic standpoint, or anesthesia standpoint, propofol is really preferred because it's a very, very short acting and it will not influence your ability to pee afterwards. So after I had my DNC last year, and even with my hysterectomy, I was like laser focused on the anesthesiologist saying, dude, I want to be able to pee on my own within 10 minutes of waking up. I do not want you to send me home 8 hours later without being able to pee and in a urinary retention. And he was like, why? And I go, because I have IC. Urine in my bladder hurts, period. So he goes, I got you. And so they did propofol. It's very, very short acting. And you know what? Within 5 minutes of waking up from my DNC, I was able to pee on my own, no problem at all. And within 20 minutes of waking up from my hysterectomy, I was also able to pee. Yeah, baby, that was good. And then when your urologist comes into the room beforehand, I want you to say a couple of things. I want you to say, now, doc, I want a low pressure, short duration. I do not want you to stretch my bladder to any great degree. I want you to be as gentle as possible, the way the AUA says you should be. low pressure, short duration. And then number two, I want you to ask him what he plans to do or she plans to do if they find anything. If they find a lesion, how are they going to treat it? Because it should be treated at the time. You don't want to be diagnosed with lesions and have to have the procedure again in 2 months to treat it. Normally, they treat the lesion when you have the procedure done. Okay. Number three, make sure that they're prepped to take pictures. You want to walk out of that OR and that procedure that day or at your follow-up appointment with pictures of your bladder so that you can show it to any other doctor and show it to family members. So, man, if you got a wounded bladder, if you got a bladder that is bright red, being able to whip out that picture and show a family member or a friend is huge. Absolutely huge. Better yet, a video. If they have a video of it that they can give you, that would be incredible too. Normally, they will also give you an antibiotic. Usually it's a shot or a pill during the procedure. I mean, usually it's a shot during the procedure. When you get home, what you're going to find is the anesthesia is going to be lasting for a bit and then it's going to wear off. And you're not going to some people, believe it or not, they go out to dinner afterwards. Others go right home to bed. Hard to know how you're gonna be. I can't tell you how you're gonna be. Uh, Having some pain medicine for a couple of days is perfectly normal. If the doctor will give you a couple of Norcos, 4 or 5 Norcos to use the first couple of days, that would be incredible. When I take pain medicine, because my body is super responsive to pain medicine, I take 1/4 of a Norco. Other people might need to take more, but having a little pain medicine on board is reasonable. And so hopefully they will give that to you, as well as acetaminophen, anything like that. Normally within a couple of days, you be back to normal. As long as they don't stretch your bladder or injure your bladder, you're good to go. And again, now that we're doing low pressure distensions, injuries are few to extremely limited now. They're much rarer. If you notice at day 3 or day 4 that your symptoms get worse, you could have picked up a post-op nosocomial bladder infection from the procedure itself. When you introduce an instrument into the bladder, that's always potentially pushing bacteria into your bladder. And so if you find that your symptoms get worse 3 to 4 days afterwards, especially if accompanied by fever, the odds are you have infections. They happen routinely. And so just be on top of that. I'm really happy that you're having it on a Monday, because if anything happens, your doctor will be there for the rest of the week. I do not recommend having hydrodistensions on Thursdays or Fridays, because I don't want you to be without medical care that weekend. It's better to have them on a Monday or a Tuesday or on a Wednesday at the latest, all right? Don't be afraid. Listen, millions of people have hydrodistension with cystoscopy, myself included. I got through it. Don't freak out about it. It's going to give you good, solid, valuable information. And to me, that's important. I'm not against hydrodistensions at all. I just want them done with the correct protocol, because I think the information you gather from it is very, very meaningful. If it's clear and you have a normal bladder, that is a tremendous success, and I would be very happy for you, because that then means that we don't need to concentrate on bladder treatments for you. We're going to look instead at muscles and other things that could be triggering your symptoms, like a fibroid as an example. In contrast, if your bladder is covered with wounds, then that's also a tremendous victory, because now we know what the issue is, and now we know to dive into the bladder stuff and the diet stuff. And you'll have good evidence to give your family members and friends who are messing with you, okay? So make sure you get those pictures if you can. You're gonna be fine, Erin. I think everybody in this room, we've been where you are. I was there 2 years ago. I want you to do my favorite anxiety management tip, which is anytime you have a negative thought about it, visualize a stop sign. Just take a moment, close your eyes, and visualize a stop sign. It's just like stop for a moment. Then take a nice, slow, deep breath in for 3 and out for 3. And then minimize the thought and say, you know what? I'm not God. I can't predict the future. For all I know, this test is going to be so easy. I'm going to walk out with a giant smile on my face and ready to have dinner. Do not do not allow yourself to catastrophize over it and assume the worst. Okay, balance the negative with the positive. Positive thoughts, because it's true. You're not God, and I'm not God. So all we can control is right now. So rather than allowing myself to fall into a panic attack, I'm going to do my stop sign, deep breath, minimize the thought. Works every time. Kim, has anybody ever gone to the chiropractor and had a flare? Yes. Yeah. Because what that means then is they moved a muscle that's a problem muscle for you. So it might have been too aggressive. Stacy, is it odd that I never really have burning when I urinate? I can have pain or burning that seems to move up from the vaginal area into my pelvis, but no pain? No, not at all, because burning when you urinate is really only associated with infection or estrogen atrophy. The fact that you don't have burning when you urinate is great. I'm happy about that. But that doesn't mean that there isn't something wrong. You know, we got to figure it out. Are you bladder wall or your pelvic floor? It's hard to say. Lindsay, how common is it for urinalysis to have trace or small blood? Biopsies show inflammation, no ulcers mentioned. I imagine bladder is just showing injury. It's extremely common. I have always had leukocytes or microscopic blood in my urine. I'm not worried about that at all. The only time you worry is if you've got visible blood. Man, if you're peeing blood clots, it's a whole nother story. So again, let's look at this for a moment and let me explain why that happens. So remember, you got a mucosal barrier, you got 4 to 5 layers of urothelial cells, and underneath there, you have blood vessels and nerves, right? So let's just say your bladder wall is irritated or you've got estrogen atrophy. So you've got, or damage, whatever. You've got urine getting where it's not supposed to be right here, right? Now, this is where the magic of the human body is nothing short of astonishing, because your body can tell that something's wrong. These nerves trigger, I mean, these blood vessels trigger something that tells the body there's an invader. So what happens then is your body goes, uh-oh, I better send my fighters there. And so leukocytes or white blood cells stream into that area through these blood vessels. See, you can see these holes. See, that's the blood vessel right there. So your body sends your army, leukocytes, right to that area. But the leukocytes are in the blood vessel, right? But the damage is up here. So how the hell do the leukocytes get from here to up here? The answer is the capillaries, the tiny blood vessels open and they release them. So when they release white blood cells, they also release red blood cells. And that's why you tend to have microscopic blood flow in your urine. It's nothing to worry about. It's usually nothing to worry about unless you're a smoker. I mean, seriously, if you were a smoker, you got to understand smoking is the #1 cause of bladder cancer. God forbid you be a smoker with estrogen atrophy, because your urine gets all the carcinogens that your body's getting rid of. And if you don't have a good mucosal barrier, all those carcinogens get right into the bladder wall where they can cause bladder cancer. Okay. Let's see here. Donna down on YouTube says she has pictures of her hydrodistension, which she takes when she sees new physicians. Perfect. Hi, DP. Maribel says, I started the V Magic. Can it cause irritation at the beginning and then fades, or should I talk to my doctor to check for infection? V Magic is really benign. I use it. It's never been a problem for me at all. And I've really, really, really sensitive skin. But I've had one other patient tell me they tried the V Magic and it burned. So I don't. Could you be sensitive to one of the ingredients? Maybe. Or could you have skin so dry that anything you put on it hurts? Maybe. Yeah, and so I think you should go to the doctor, tell them that you're trying, that you've tried something because your vulva feels dry, and have them look and see if there's anything else going on. You might need an estrogen cream instead or in addition to. Lindsay, your interpretation is absolutely correct. Uh, Do lots of other ICUs show trace small blood in your analysis? The answer is yes. Biopsy shows inflammation, mention of glomerations or cysto, but no mention of ulcers. I interpret that to mean injury to the bladder wall, and my symptoms would tell me that. Sounds reasonable, but what I will tell you, at least in the papers and the studies that I've looked at, we don't see a lot of inflammation in normal bladder wall stuff. We see more inflammation with Hunner's lesions. Robin, is it safe to have a B12 shot with IC? Yeah, B12 is usually not bladder irritating, but I'm not God. I can't predict the future. You'll have to try it, but usually B12 is fine. Rocio says, hi, Jill. So even if I drink Bella Rosa decaf coffee, can it affect your healing process? I think anything like that can. Bella Rosa coffee, guys, the challenge with coffee is that it is incredibly acidic. I mean, think about it. It's brown. It looks like mud. If you had an open wound on your hand, would you pour mud on it? No. Would you pour coffee on it? Usually not. If your bladder is in the process of healing a significant wound, I think it's really, really important to back off on everything like that. I have something that we call our coffee test. And so with our coffee test, to see if you can drink coffee, and of course, if you're in a flare, there's kind of 5 steps. So step number 1, if you're in a wicked flare, you don't do anything but water and just give your bladder a break. Step 2 is to introduce chamomile herbal tea or peppermint herbal tea. If your body handles that okay, then you can go to an herbal coffee like Pero or Caffrey Roma. If that's okay, then you can go to, wait, am I missing a step? Hold on. Wait, water, herbal tea, herbal coffee. I think I'm missing. I call it the coffee challenge. Hold on. I think I'm missing a step in there. Whoops. Whoops. I'm getting out my diet guide. Here it is. Stay. Guys, this summer we'll be issuing a new diet guide. So our last diet guide is this one from 7 years ago, and not a lot has changed. I think I have the coffee challenge in here, so hold on a sec. I'm usually pretty good at remembering stuff, but I want to be as accurate as I can be with you. I know it's on our website, so you can check our website. Yeah, just check our website. All right, so anyway, getting back to that. If you're in a flare, water for a week, if it's a bladder wall flare. Then you go to herbal tea. See how you do the herbal tea. Okay, chamomile herbal tea, peppermint herbal tea. Please do not do an herbal blend like Sleepy Time because there's rose hips in it and those can be acidic. So chamomile, peppermint. If you do those, you could then try the rooibos. If you do those okay with those, you can then try the herbal coffees. I can't stand them myself, but you can try the Pero, the Ticino, the Caffrey Roma. If you do okay with that, then you can try a true, genuine, low acid, real coffee. And I have them here. I have these here because I keep wanting to do a video on it. So Tyler's Acid-free, world's first acid-free coffee. That's not technically true. It's not a pH 7, which would be acid-free. It's in the high 6s, but it's still very, very low acid. Simpatico low acid coffee has been very, very popular for many, many years now. But my personal favorite for coffees is this brand, Bella Rosa. I think Bella Rosa is the best coffee for it's a fascinating story. Acid is produced 3 ways: by the altitude that it's grown, the coffee's grown at, the way that it's roasted, and then by how it's brewed. So we have to start first with a lower elevation coffee bean. Then during the roasting process, if coffee beans are roasted in a big hot metal drum, which most of them are, an acid called, I think it's chlorogenic acid, is produced. These guys had an engineer create a brand new, different way of cooking coffee beans, and it's a hot air process with no metal. And so when they produced it the first time, and it's very popular here in California, they had a lot of customer calls saying, "Why can I drink your coffee? Normally I get stomach aches with coffee, but I can drink your coffee." And they didn't know. And so they took their coffee to the University of California at Davis to a coffee expert who studied their coffee. And what they found is it has virtually no chlorogenic acid in it, which is which is the acid which causes all the pain. So there's something kind of unique about their brewing system, their roasting system, that makes truly low acid coffee. So if you're going to try low acid coffee, I would do Bella Rosa decaf. You can find that in the IC Network store. It's carried in many California stores, even Safeway, but you can get it from us. We even had samples for a while, although I think we're out of samples. Then if you do okay with decaf, you could potentially go up to the half calf. This is a cool thing. They make a half calf coffee. And then they also have the full caffeinated coffee called Morningstar, right? But I think it's foolish. Why do people drink coffee? Because it helps you pee in the morning, and it helps you have a bowel movement because it turns nerves on. Well, the last thing you want to do with an IC patient is to make them pee more. We're already peeing a lot. So doing a strong caffeine doesn't make any sense for us. So the half if you're one of those people where you really need a little bit of caffeine for one reason or another, the half calf is the way to go. Okay. Bella Rosa coffee is in the IC Network. Just go over to our website, icnetwork.com, ic-network.com. Click on shop. You can go into our shop, and you can look at the coffees over there. That's how we pay for these meetings, guys. We sell books and chair cushions and heating pads, and even the supplements like Pre-Leaf and Sister Protect and Sister Renew. You'll find those. Lori says she had 27 cystoscopies with DMSO in 9 years. Woo, holy moly. DMSO is the only FDA-approved bladder installation for IC, but it fell out of favor a decade ago. It's not done nearly as much now. Instead, what they do instead is a rescue installation with heparin and lidocaine. We know that DMSO at the FDA-approved concentration of 50% can cause bladder spasms, if not irreversible bladder spasms or muscle spasms. You'll find that research on our website. That was presented at the American Urology Association 2 years in a row by researcher C. Suba Packer. And when that research came out, pretty much all the top urologists agreed that they would no longer do DMSO as a straight 50% dose. It would always be done in a cocktail formula to reduce the dose to about 25% to 20%. Sylvia, what is the medical terminology for bladder wall thickening. Yeah, there is a term they use. It's not coming to mind. I mean, bladder wall thickening is pretty self-explanatory. Nancy, what is the difference between lesions and glomerations? Well, let me show you. I can just show you a picture. All right, a lesion. So here are 16 different bladders, each with lesions. Lesions are very bloody. They are known for a waterfall effect when they get stretched, because the center of strong inflammation is very thin, and any amount of pressure on it will usually rupture it. So with a lesion, there's usually a center area, and then there are kind of lines. It's called a stellate appearance. It looks like a star. It has lines going different ways. Whereas petechial hemorrhages are like red dots. So this is a really good example of what an injured bladder would look like from chemotherapy or from ketamine, whereas this is potentially what a bladder might look like if there is a viral infection. And again, as I said earlier, understanding the origin of these lesions is really one of the great challenges confronting the IC researchers. I mean, we've got actually, I think more than two, I think 4 compelling studies that suggest that these may be viral infections, different types of viruses, whereas this is more like a superficial injury or trauma from something. It's funny how they, it looks like, I used to describe mine as sharp nails going down my bladder wall. And isn't it funny that that's exactly what that looks like? It's like somebody took a sharp nail and just scraped it down. Catherine, I've been on Ditropan XL for 15 years. Should it be used only during spasms or all the time? Well, hon, the thing is you're on Ditropan XL, and Ditropan XL contains ingredients on top of the oxybutynin, and it's probably the other ingredients that are really helping you. The challenge with Ditropan and products like that is it kind of numbs your ability to pee, and it makes it hard to pee afterwards. So taking it for 15 years is a really long time. But if you're able to empty your bladder normally, then that's good. I would do some more research on that. I mean, I would go to drugs.com, look up Ditropan XL, look at the side effects, look at anything else that will give you kind of any clues on if you're experiencing any adverse events from it, and maybe is it time to do something else. Catherine, also, again, quality and health of your skin. If you've got estrogen atrophy, Ditropan is going to calm the symptom, but we want to get to the root problem, which is dry skin and lack of mucus. And, I would be wanting to address the mucus issue with either something like Cysto Protect that might help cover and protect the bladder wall. Cysto Protect, Desert Harvest Aloe, Cysto Renew. And I'm very delighted to share that Bladder Builder, the brand new supplement Bladder Builder, should be here by the end of the month. It's very, very exciting because it's the first supplement that, so it's got chondroitin for the bladder coating effect. It's got quercetin for the antihistaminic effect, just like Cysto Protect and Cysto Renew. It's got 5 probiotics in it for good, healthy bacterial flora. But the killer ingredient in it is PEA, which is phenylethylalamide, something like that. PEA has multiple research studies for pain-reducing properties. And I'm just delighted to share that in 2 weeks, the first IC study with PEA is being publicized at the American Urology Association conference. Boy, did we pick the right time or what for the supplement. They conducted their first formal study of PEA with IC, and at the end of 3 months, 75% of the people who used it had a significant reduction in their pain. So once I have it in hand and have a bottle to show you, we'll be doing a special broadcast on that so that you can learn more about it. I will tell you that it is being developed with the help of Dr. Ken Peters, the top IC researcher in the United States. We already have patients that are using it. And in fact, something really hysterical happened last week. We got an email from one of the doctors saying, well, I mean, it was done in a funny way, where he said, thanks for nothing. I'm losing money. And we were like, it's like, why? He goes, because I had a patient who is doing so well on the PEA. I don't have to do anything else for her. And it was actually a congratulatory email. It's like, you rocked it. You did it. So he wasn't, he was doing it in a joking way, but that's incredible. That here was a patient scheduled for a hydrodistension and for, I think, Botox. And in the pre-op, she was pain-free from the supplement. And they decided not to do the more aggressive procedure. So obviously it's early days. We're going to be doing a lot more research on it, wanting a lot of patient feedback about it. It's something that I've been helping with for almost a year now. And it's really, really exciting to have a supplement that in fact has pain reducing properties. Just what we need now with this opiate crisis. I do have to give you a warning though, that with the PEA is a very, very expensive. Without the PEA, we would have been able to sell it, in the area of $39. The wholesale price, I kept saying to the company making it, it's like, I need it under $40. Please give us something affordable, right? And that's what we were doing all along until we were able to get PEA, until they were able to get PEA. And we just felt it was so appropriate to have a pain fighting property in it. Unfortunately, that adds $10 to the bottle in terms of cost. So now we're going to sell it probably for $44.99. Within 3 months, it's going to go up to $49.99. And within another 3 months, it might be at $55. I don't know. It's all about how the contracts that they're negotiating with the P company in Europe. All right. So we also had a conversation about creating the supplement without the PEA, having a really simple supplement that would have similar effects, but without the cost. And if it does as well as we think we are, I think we'll be able to do that too. And when I say we, I'm using that. The IC Network is not making this. It's another company that's making this, but I'm working with them. And we're just trying to create options. So when I say we, it's they, but I'm part of that discussion, if that makes sense. Rebecca says, I take B12 injections, also take a multivitamin shot that has amino acids. It doesn't even has to be vitamins. And they help her. Good. Kim says, it looks like you need a doctor's order to have your urine checked through bladder health. Not in 25 countries, hon. You got to go down to the bottom and look at the country list. I mean, 25 states. In some states, you can order it on your own, like in and then in other states, you will have to have your doctor's signature. But it's a piece of cake. It's routine. It's just like, doc, listen, I'm trying to cover my bases. I want to make sure I don't have a fungal infection in my bladder or anything else. I'll pay for it. Can we just take a look at it and see what this next gen test finds? Thank you, Svetlana. Thank you, Tamara. Alexis, I have no burning, but mainly pressure on my bladder. It's a constant painful pressure, no infections and pain when peeing. Tested both at doctors at home. So listen, girl, then you're looking at pelvic floor, or I mean, think about what you just said, what you just wrote. I have pressure on my bladder. Well, here's something that causes pressure on the bladder: a fibroid. Is there any chance you have a fibroid? Um, let me tell you another really interesting case. Um, and I might have said this last week too. We have a local pub that has trivia night, and so I've been going, and I have my one little tiny bit of pear cider, right, or just sparkling water. So we didn't have a lot of people, so we joined with another group one night, and one of them was a retired doctor. And there were four of us. There was a guy and three girls. And when the guy left, we were just talking. She goes, "What do you do?" I go, "Well, I work with pelvic pain and interstitial cystitis." She goes, "Well, I have a really interesting pelvic pain story to share." And it's like, all right, I love that stuff. Tell me what you got. So she was an internist, right? And she was a runner. She ran 18 to 20 miles a week. And all of a sudden, she had blood in her urine. And it made no sense. They did a cystoscopy, they couldn't find it. And then she started getting pain while she was running. And the pain got really, really bad. So she had to stop running. And they did CAT scans, MRIs, anything. Couldn't find anything. Then she was having trouble walking. It's really, really bad. More tests. And, I just got to say that it's amazing. Doctors treating other doctors can be pretty mean. And so she was getting that it's all in your head thing, all in your head message, right? And then one day it was particularly bad, and she had to push a little bit to pee, and out popped into her toilet an inch-long string of stitches, blue plastic polypropylene stitches. She's looking at the toilet going, "What the hell?" Because, stitches, if you've ever had them, they look like little caterpillars. They've got little edges, right? She's looking at the stitches, and unfortunately, she just flushed them down accidentally, but she went back to her urologist and said, "Stitches came out of my bladder. What is this?" And she felt better. She felt immediately better when the stitches came out. But then it slowly came back. The pain got worse and worse and worse again. They did more tests, couldn't see anything. And they finally it was so bad, they did a laparotomy to look in her bladder, laparoscopy. To look in her belly. There were dozens of floating stitches in her belly. And everywhere they were this knot of red tissue inflammation. Polypropylene is what's in mesh. That is why the FDA banned vaginal mesh this week, because it was never meant to be in the human body. It gets hard, it changes shape, and it migrates through tissue. So she literally had a tummy tuck 22 years earlier. And she remembers that a young medical student was doing the surgery, and it obviously was being supervised. And the medical student accidentally used the wrong sutures inside her belly, and she had 100 of them. These type of stitches are only meant to close wounds. They're not meant to be used inside the belly. Somehow they got used inside her belly. 22 years later, they started migrating throughout her body and through her bladder wall and out her bladder. And she's like, she was astonished and her doctors were astonished, and everybody ended up apologizing to her, and they got as many as they could. Some are probably still in there floating around. She goes, "Have you ever heard of that before?" And I went, "Believe it or not, yeah, because I've worked with another patient that happened to too. I had another patient who had just severe, unexplainable bladder symptoms. And but this time when they did the hydrodistension, they found a stitch sticking through her bladder wall. And when they pulled it out and got it out, her symptoms went away. So that just shows you that there are many different things that can trigger bladder symptoms. It's fascinating. So Elizabeth getting is pushing the envelope a little bit here, but I'm going to read to you what she wrote for you on YouTube. She says, I treated my IC using chelation and homeopathic remedies used to combat vaccine damage. I treated my IC as a vaccine-induced autoimmune disease it was, and my bladder living literally healed itself. I used to be on 8 medications, had many surgeries, was nearly completely disabled in excruciating pain. You are not defective or deficient in any way. You are a victim of a profit-driven medical system in this community. You now live free. I work to educate others. No question here. I found my miracle. So, I completely respect your perspective and opinion. As I have said before, there are many potential things that can trigger IC symptoms, from polypropylene stitches to tight pelvic floor muscles to chemotherapy for cancer to chronic fungal infection. And in your case, you're thinking that it's a vaccine induced autoimmune disease. I don't have any evidence to associate to confirm that, any at all. Is it possible? I don't know. I don't want to minimize your perspective in any way. You are feeling incredibly good, and I just say power to you for feeling good. Is it possible that the diet you were doing and all the other things you were doing were facilitating healing? Absolutely. And so I think there's a whole picture we have to look at, but remember, I see. So here's the thing which defeats that. I have to tell you, the thing which kind of defeats your argument is that IC was discovered in 1840 or 1850 in England, well before they even made vaccines. So all the way from 1850 to 1920, 1930, when they invented the cystoscope and they could look at the lesions in the bladder, there were no vaccines to be had. So we cannot make a cumulative cause and effect statement based on history. But I completely respect your opinion and your perspective. I just think that, unfortunately, we have to be really careful with vaccine fears. Measles was cured in this country and now it's back, and it's a terrible situation. I'm not afraid of vaccines. My training was in pharmacology. I had the MMR vaccine. I had measles and I had chickenpox the same month when I was in kindergarten too, by the way. And so I'm deeply worried about what's happening with measles right now. So I can't jump on that bandwagon, unfortunately. Lindsay says only some bacteria produce nitrogen. You're right, Lindsay. You're absolutely right. That's the simplified version. And Nancy says amino acids are extremely irritating to my bladder. Recently read 4 amino acids convert to norepinephrine, epinephrine, and epinephrine. Amino acids are in all the foods that we eat. And so if we were to follow that line of thought, then our daily diet would be triggering really bad things in our bladder. I think this is about quantity. It's about quantity. If you're taking an amino acid over the counter, lots of it, L-arginine, L-lysine, anything like that, again, I come from a less is more perspective. I don't believe in taking a lot of extra stuff, hon. I just don't. A little goes a long way. But our foods are composed of amino acids, especially proteins. Robin says, I've not done it yet. You're inquiring due to no energy since your partial hysterectomy. Robin, recovering from hysterectomy is a beast. It's a beast. It's a hard surgery to recover from. Take it from me. I've been there. Stephanie, how often can we take Peridium? One doctor told me 2 to 3 days a month. Another told me take it every day. Peridium is meant to be a short-acting medication. Generally, it's really only taken for a few days at a time, only when needed. It was really never meant to be taken every day over a long term, although quite a few patients have. But there are some concerns with either liver damage or kidney damage. I don't remember which one it is. You can Google it and read more about it. Valerie says she was given so many antibiotics from doctors thinking she had an infection that she almost ended to die from Clostridium. Absolutely. And I'm telling you, if there's one patient population completely overexposed to antibiotics, it's the urinary patient. And that is why we're very, very clear. Please stop self-medicating yourself with antibiotics if you think you have a flare. Please stop doing that. We have a severe problem with antibiotic overuse, not only with humans, but especially with our feed animals. 90% of the antibiotics made millions and millions of pounds never make it to humans. They're in the food we eat. And that is a terrible shame because it is creating the perfect environment for these drug-resistant bacterial infections and fungal infections. We now have the new Candida auris. I think you pronounce it auris, super resistant Candida infection, which they think is a result of using certain antifungals on fruits and vegetables. We got to go back to organic. This is ridiculous what's happening. No matter what mankind does, mankind is very arrogant in thinking that we're smarter than the earth, smarter than basic biology, and we're not. And so many things that we do are so incredibly damaging over the long term to our environment and to our bodies. Anything you can do to get back to nature, to get back to simple, fresh, healthy, organic food is the right way to go, rather than fast food, processed food. If you're buying eggs, buy cage-free eggs, not treated with, where the chickens are not treated with antibiotics. If you're going to buy meat, try to buy from a local butcher rather than these massive pork farms, where these super resistant infections are being found. Same thing with chicken. I buy Rocky the Range chicken, which is made in a local town, grown in a local town. But I really stay away from national brands where you don't know. I call it mystery meat, where you don't know where it's coming from. Like sausages, like as an example, Jimmy Dean sausage. I don't know where that meat comes from. My assumption is it's from a giant hog farm. That makes me a little uncomfortable. If you can, plant your own garden. I just planted half of my garden yesterday. I got peppers, I've got zucchini, I've got eggplant, beans, and the tomatoes I'm planting are going to be the low acid yellow cherry tomatoes. Yellow tomatoes are lower in acid than the red tomatoes, but homegrown tomatoes are just much better anyway. They have much less acid. And remember, guys, with tomatoes, it's about quantity. Listen, a cup of tomato sauce is the acid of a dozen tomatoes that have been squeezed. That's a lot of acid. Yeah, that's probably going to hurt. But one slice of tomato on a sandwich is probably not going to hurt you because there's very little acid on that one slice of tomato, unless you are really, really acid sensitive and have Hunner's lesions. That's another story. Oh, wow. Marion says they suggested a spinal stimulator, so I would assume that's Interstim. That's a step 4 treatment intervention. Come to our website, watch our video, the 6 steps of treatment. There are 2 different forms of neurostimulation, one at the spine, one at the ankle. The one at the spine, known as Interstim, is associated with hundreds and hundreds and hundreds of very, very severe complications, including fatalities, according to the FDA. But the biggest issue with Interstim is the deep tissue MRSA infections. If you go to the FDA MAUDE database, you will see them. Like the old TV show MAUDE, MAUDE. Go to FDA MAUDE database, search for that. It'll take you straight to the database. Go in, search for Interstim, and just put product name Interstim. Just go the last 3 months. You'll see a couple hundred. I mean, the adverse events are constant with Interstim. Whereas the ankle stim, known as Urgent PC, hits the same nerve, but down at the ankle where it's closest to the surface of the skin. It requires no surgery. It's just an acupuncture needle. Very, very few side effects. I was one of the first patients to do it, and I think I can show you my tattoo from it. Let's see. I don't know if you can see that little black spot right there. Little black spot. That was So when you have it done, it's 3 fingers from the top of the ankle bone, right? So it's about here, but it's not halfway. You have to actually have to go down. And then when they put the needles in, the needle placement is the finesse. That's how you know if the person's doing it well. If so, the needle doesn't go straight in like that. The needle goes down a little bit and forward a little bit, right? So you know the needle is in the right place when they turn it on if your big toe flexes down or your finger or your other toes splay out. If the big toe flexes down, perfect position. If the big toe doesn't flex down but the other toes flay out, almost perfect position. If nothing happens, they've missed the nerve. So I was one of the very first patients to go into that program, post-tibial nerve stimulation. It was invented at UC San Francisco by Dr. Marshall Stoller. I was one of his patients. I had my first 2 hours without pain at week 4. I had my first day without pain at week 7. It broke me out of a 1-year agonizing flare. So when it comes to neuromodulation, it has a role. It can really calm those nerves down. The question is do you do the surgical interstim or do you do the non-invasive ankle PC? Most people start with the ankle PC because it's much, much cheaper. Marion, a couple of things about the interstim spinal stimulator. Aside from the side effects, you have to make sure that it's covered by your insurance. We had a nurse who lived in a small town back east. There were 3 urologists in the town. They all agreed she should have Interstim. They all told her they would not treat her unless she had it done. She felt somewhat forced to do it, but she did do it. But she did what she thought was her due diligence. She talked to the billing person in her doctor's office and said, "Is this covered by my insurance?" They said yes. She then called the hospital. "Is this covered by insurance? Does it require a written pre-authorization?" They said, absolutely covered. No written authorization is needed. Then she even called the insurance company and said, "Is this covered by my health insurance? Do I need pre-authorization?" They said, absolutely no written authorization is required. So she had it done. She didn't get it in writing. A week later, she had a bill for $80,000 and a threat to garnish her wages because she was a nurse at the hospital. So you always want to make sure that you know that it's covered by your insurance. Don't accept a oral authorization. Get it in writing so that you've got something to back yourself up on. If she'd gotten in writing, she could have really hammered them. I don't know what happened to her. I think they garnished her wages. I don't know. The other thing with Interstim is that if you lose your health insurance, your doctor might stop seeing you, and having a medical device requires constant medical attention. So we had a patient in Florida who lost her job-sponsored health insurance. She ended up on Medicaid. Her device malfunctioned. It was shocking her. She called the surgeon. He refused to see her because she didn't have insurance anymore. And she didn't know what to do. Nobody would see her because she didn't have the insurance. She just had Medicaid. She called me hysterical. We hooked her up with a company. The company hooked her up with the one doctor in the entire state in Florida who would treat her at that time because he would take Medi-Cal. So I would just say to the doctor, "Listen, if I lose my insurance, will you care for me?" And if he says no, I would back off. I would just say, "Where do I go?" He's going to say, "I don't know." And it's like, well, you're giving me a device. You're telling me it needs to be monitored every month or every quarter. And if I lose my insurance, you're not going to monitor it. And I'm going to have this device stuck in my body. Oh, hell no. No, no. I need a promise from you that you're going to care for me, even if I lose my insurance, period. And if he's not willing to make that, I would move on. But that's me. But, we're kind of left to pick up the pieces of the patients who are, who have been abandoned by their doctors and their health insurance. Maribel said she had to stop the estrogen cream because it made it worse. As soon as I stopped it, it felt better. Maribel, listen, you got to understand that if your skin is dry and you put any chemical on it, it's going to hurt. Estrogen cream it gives you a warm sensation, even a hot sensation when you start using it. That's normal because your skin is dry. But what happens over time is the more you use it, your body produces mucus, and that's visible. They can see it in research studies. They can see more skin cells being produced, more mucus being produced because of the estrogen cream. So if you stopped it because it gave you heat, yeah, you're going to feel better because it's not giving you heat, but you're still going to be estrogen atrophied. Also, if you were using Premarin is notorious for causing pain because it comes from pregnant mare urine. There are a lot of extra chemicals in Premarin that can be irritating, whereas a compounded preservative-free estrogen cream, which is what I use, may be more tolerable. Hello, Susan from Austin. Dr. Parsons is doing a study treating IC using hyperbaric oxygen therapy. The study, as I understand, is a treatment indicated for a person with cystitis from radiation or chemo. It sounds promising for IC. Being sensitive to many meds, I wish I could participate. Are you familiar with this treatment? Well, not only am I familiar with this treatment, my dear, there is actually an article on this in our last magazine. Hyperbaric oxygen therapy. So come get our magazine, hon. You guys, come on. If you find these support group meetings helpful, please help us by becoming a member, and you're going to get good information here. The information that we put in this magazine usually does not come onto the IC Network website for 6 months. Because I got to have something that is unique for our members, right? So yes, hyperbaric oxygen therapy. There are multiple studies, and that article will tell you what they are. Brittany says she uses Desert Harvest, their multivitamin B that does not have B6, and it works great for her. Yeah, that's one of the cool things about Desert Harvest is they really listen to patients. Lana and Danny, hello from Irvine, Kentucky. I drink kava coffee. Yeah, kava coffee is another good example of a low acid coffee that's instant. I just can't get it out here. We can't get it out here, and unfortunately, we can't sell it either. But yeah, kava is another option for you. Maribel says uses IBS, uses the Bella Rosa decaf, and it doesn't make you sick. Awesome, glad to hear it. Hello, Cher down on YouTube. Hockey Player 20 asks, can anybody help you? Well, Hockey Player 20, if you happen to have interstitial cystitis or pelvic pain or pelvic floor dysfunction or chronic prostatitis, yes, we can help you. Cher, I've had the pudendal nerve stimulation. Didn't help me though. It may help others. You have a video of your pudendal nerve stimulation procedure. Yeah, Cher. Hey, Cher, I would love to see it. I would absolutely love to see your video, Cher. You can message me on Facebook, or I'll try to message you. icnetwork@mac.com is my message. Sophie is having a bladder installation tomorrow. Sophie, what are you having? What kind of installation are you having? People, seriously, do not be one of those people who call me and say, I've tried every bladder treatment in the book. And when I say, well, what'd you do? And they go, I don't know, they put it in my bladder. And I was like, well, what was it? I don't know. Okay, guys, seriously, do not let anybody put anything in your bladder unless you know what it is. We no longer do silver nitrate. We no longer do chlorpactin. Those are badly damaging to the bladder. So don't give them an open invitation to put whatever they want in your bladder, okay? You have to be prudent here. Let's make sure we know what it is first, okay? Rebecca, when will Bladder Builder be available in the United Kingdom? We will be able to send it to the United Kingdom through the IC Network by the end of the month. It's hard. It's very hard for us to send supplements, especially to the European Union. Their customs often forbids supplements. Granted, I'm so sorry about what's happening in England, and I'm so You guys are in as much chaos as the United States, really all driven by Russia propagandists, and I'm so sorry about that. But yeah, we'll be able to send it to you. Bladder Builder. Bladder Builder. Kelly, can you pre-order it? No. Actually, I would take that back. I can take pre-orders over the phone, but I can't process them. We can't put them in our store because we're not allowed to process a credit card until we have the product to ship. There has to be a 24-hour turnaround. But I think maybe what I'll do is I'll have my Heather up in our warehouse start taking advance orders, and I will start taking advance orders through the IC network too. Svetlana, are there good exercises for pelvic floor muscles at home? There are, but we need to know what muscle because you treat muscles differently. So the psoas might be treated one way, the piriformis might be treated another way. You can't really make it up. You can't just go, hey, I got pelvic floor dysfunction and start doing Kegels. You're going to make it worse. You really have to at least once work with a pelvic floor physical therapist so that we can so that you can identify which muscle are the problem so that we can do a customized program for that specific muscle injury because they're not all the same. If you're doing Kegels thinking you're going to help a pelvic floor dysfunction, you're going to make it worse because Kegels are designed to tighten muscles. Hockey player. Hey, hockey player, are you a guy or a girl? If you could tell me if you're a guy or a girl, that'd be really helpful for me to answer that question. Also, Svetlana, we have a couple of really good books. We have Ending Female Pelvic Pain and Heal Pelvic Pain over in the IC Network store. Go check those out. Buy one of them. Learn it, read it, memorize it. You're going to use it. You will use it hands down. My favorite is the book Ending Female Pelvic Pain, which I have. Here. All right. So the books. You know, wearing a long dress while sitting in a chair and doing a lecture was not the best idea. All right, the Interstitial Cystitis Solution, written by Nicole Kosian, who is our 2017 Physical Therapist of the Year. It's the first book which really explains the bladder pelvic floor connection. And as you can see, I've got lots of Post-its in it because when I get books like this, I believe me, I dive into them and try to learn as much as I can. Okay, so this would be one book that would talk about the bladder and the muscles, Svetlana. The book that I really like that doesn't talk about the bladder, it really focuses on the muscles, is Ending Female Pelvic Pain. And you will learn more in 5 minutes reading the introduction of this book than you will have no intent. You know, I took anatomy. I mean, I took good classes, and yet, oh my gosh, this book was so good. It helped me so much understand the muscles and things that I was doing. One of the things that you can do when you have, okay, it's called the prayer squat. Just squat down like, so if you're at the bank and you start feeling your pelvic floor muscles get tight, just drop your keys and just squat down on the floor just for a couple of seconds. When you squat in this position, it puts your pelvic floor muscles exactly where they need to be. So this is an absolutely excellent position. And then for the men in the room, the same author has written a book called Ending Male Pelvic Pain, which is also incredible and happens to use men in the pictures, right? So if you have any sort of muscle stuff, seriously, you know what? God didn't give you the knowledge to deal with pelvic floor dysfunction when you were born. You got to learn it. You got to read it. You got to get your education level up. These books are the way to do it. Also, if you're struggling with really, really intense pain anyway, and you're trying to get some control of your pain levels, there's no better book than this book, When It Hurts Down There. This is written by Dr. Angie Storr. I featured her in one of our magazine last year with an extensive interview. She's an OBGYN in Texas. This book is kick-ass good. She talks of, I mean, it's just get it. Just get it. It's good. It's really, really, really. I've done whole lectures on it here online, but she talks about the triggers of pain and pain processing. So here's a really interesting picture from this that I think helps us understand why patients have IC, IBS, and vulvodynia at the same time. You know, with my yeast infection last month, what was happening is I get this really extreme vulvar pain. And then 2 hours later, I'd have bladder pain for 2 hours. And then 2 hours later, I'd have rectal pain or bowel pain. And it was just like cycling through my pelvis. And this explains why. Because all the nerves in your pelvis do end up converging up at the spinal cord. And there's something called neural crosstalk, where nerves talk to each other. So we know that when the bowel is irritated, the bladder will become irritated. When the bladder is irritated, the bowel will become irritated. That's neural crosstalk, and that's actually happening up at the spinal cord. They've also done kind of tracer studies where they will put a one tracer in a bladder nerve and another tracer in a bowel nerves. And when they follow them with testing and with x-rays, they end up converging and they end up in the same nerve. And so that helps us understand why so many structures in the pelvis can be involved with pain. So all these books are available in the IC Network shop. My favorite thing in this book, aside from pain processing, and it really tells you how to interrupt pain at the bladder, at the spinal cord, at the low brain, at the midbrain, and at the upper brain, those all present opportunities to stop pain and to reduce pain. So one of the things that you could do is slap your thigh. When you're in pain, just slap your thigh. When you slap your thigh, you're interfering with the gate at the lower brain. You know, your body has tens of thousands of pain nerves. If they were all arriving at your brain at the same time, you would be insane. We would be insane. We would feel pain throughout our body. We have something called the gate mechanism, and that's at the lower brain. So all these pain nerves come up here, and at the lower brain, it decides which pain message is more urgent and that goes higher to the midbrain and eventually to the upper brain. So one of the ways that you can reduce pain sensation is just slap your thigh like that. I remember I flew to Europe doing this. I had a TENS unit. Actually, I had a TENS unit that was doing it too. So anyway, great tips in this book, and it's very, very inexpensive. It will really help. I promise you it will help. And in fact, let's do a freebie. Here's the freebie. We are going to do, hold on, let me get my Post-its. Where are they? I'm going to write down a number between 1 and... Now, some of you have said you can see what I'm writing. I don't know how you can see what I'm writing. I'm trying not to move. Okay, I'm gonna move my arm in a whole bunch of other ways. All right. And hockey player, just hold on. You're next. So we are going. I'm gonna have you. Okay, so hold on a sec. Don't vote yet. Okay, just know that when we start voting, I'm gonna lose some messages on Facebook. So hold on. Let me just look at these real quick. All right. Okay, guys, start voting now. The first person to come, you can vote on YouTube, on Facebook for the first pick. The first person that comes up with this magic number that I've written down on this post-it will get this book. Go for it. You can vote many times, literally. Just keep voting. The first person who gets it will get the book When It Hurts Down There. Oh, one of you is very close. Keep voting, keep voting. Keep going, keep going, keep going. Think of it as an Easter egg hunt. Not yet. And believe it or not, I'm actually holding up the post-it, which I shouldn't be doing. Nope, not yet. I'm looking at YouTube too. I don't see it yet. Nope, nope. And if I screw it up and two of you have said the same number, I will send out two of them. But right now, I don't see anybody who's done this number yet. Nope. Nope. No. Lindsay, 109. I'm looking on YouTube real quick. I don't see it on YouTube. I'm not. Oh, you guys, you're like dancing around it. Okay, one person has the opposite. The correct number is in the wrong form. I mean, that was a giant hit. A giant hint, guys. Oh, you're killing me. Oh, Donna Townsend. Donna Townsend, here's your number. 35. Now, if I missed somebody, if somebody actually said that earlier, please tell me. I know, Carrie says, this always happens. It does. Donna, if you can email me your address, hon, I'll send you that book. Okay. Look at that. We've been on for 2 hours. I was thinking we'd only be here for a half an hour because I didn't think anybody was going to come to this meeting. That's hysterical. Oh. So on the whole vaccine thing, and I'm sorry, the message scrolled by, and so I apologize that I cannot get to that message right now. It doesn't explain why fibroids would trigger IC or a migrating stitch, or I mean that guys, if there's one thing that's kind of doomed the IC movement early on was the assumption that we were all the same. We are not all the same. IC is not an incurable bladder disease. Okay, we have subtyping now. There are many variants of subtypes. Patients with Hunner's lesions versus somebody with a migrating stitch, somebody with a fibroid versus a tailbone pelvic floor injury. We cannot say absolutes anymore. It does not work. Is there a possibility that there's a group of patients out there who might have developed an autoimmune thing from a vaccine? Maybe, but that does not explain the fibroid connection and the muscle connection and the patients who were sexually abused and whatever. It doesn't. So we cannot make blank statements anymore. And I just really I need you guys, especially on Facebook. Guys, I rant about Facebook. I don't mean to, but I do, and I'm sorry. Because there are really nice people on Facebook, but one of the flaws of Facebook is absolute statements. You've really got to respect the fact that a patient you're talking with might have a different subtype. They might have a different variant. Like, as an example, we had a patient who's come to our meetings who was in one group, extremely depressed, despondent, literally laying in bed reading Facebook all day. She wasn't even watching TV. And she was in bladder groups, and they kept saying over and over, do Elmeron, do all this sort of crap, right? She wasn't going to the doctor. She finally connects with me. I talk with her. Her symptoms were strongly suggestive, not of a bladder wall issue, but of a muscle issue and of pudendal neuralgia, of which none of the bladder treatments would have any help at all. And when she finally got to the right doctor, she had bilateral pudendal neuralgia. She had muscles so tight they were squeezing nerves. None of the bladder treatments would have worked for her. And that's all what everybody was saying for her to do for months and months and months. So you really, really, really have to understand that this landscape has changed. You know, there was a doctor years ago who went on Dr. Drew who called IC a grab bag diagnosis, and we were really offended at the time. You know what? I hate to say it, he's kind of right. It's like everybody with a lower urinary tract issue is thrown into the IC bandwagon. And that's the whole reason why we have to do subtyping. It's working so well now. And there are people in here who know it's working because it's helping you. So have you ever heard of using heparin and triamcinolone acetate in the bladder as needed? Absolutely. It's called a rescue installation. Heparin, lidocaine, triamcinolone, maybe a little antibiotic. You're gold. Rescue installation, most popular IC therapy out there. Okay, Catherine Fawcett on Facebook. You also guessed number 35, so I'm going to send it to you too, my dear. If you also guess 35, I will send the book to you too. Okay, Catherine? Somebody just said. Somebody said that you would guess a number, and because I can't see both streams at the same time, I will send it to you too, my dear. Okay, so you just email me, message me your mailing address, and you will get it. All right. I just have to make a note here. No, guys. We've got plenty. We've got plenty of books. Mary Jo says she takes azanthin. I have no idea what that is. Let me ASTHCANTHIN. Terpene. Oh, it's carotenoid. Okay. Oh, Oh, you know what? That is the active ingredient in what did they call it? It was recommended for vulvodynia patients, and it was from algae. My mom used it for years, really successfully. All right, hockey player. Okay, guys, we got to get to hockey player here on YouTube because hockey player is definitely having issues, and I want to see if we can help. So, luckily on YouTube, I can scroll backwards. So, hockey player has been diagnosed with IC, no pelvic floor dysfunction, but severe urgency 24 hours a day, no satisfaction after urinating. What else can I do besides Elmeron, Mirbitric, and bladder instills? So you had the hydrodistension. Did you have a hydro? You have severe urgency 24 hours a day, no satisfaction after urinating. What else can I do besides Elmeron? Okay, so hockey girl, what What's the condition of your bladder? So, did they see anything in your bladder at all when they did the hydro? So you guys, I'm going to give you a sample right now of coaching. This is what I work with. This is what I do with patients on the phone to try to flesh this out a little bit more. Severe inflammation in your ureters. Have you been exposed to ketamine at all? Ketamine, you know what that is? Ketamine is a chemical that they've actually been giving to patients with severe depression. Okay, good. Ketamine is also kind of it's it's a veterinary anesthetic known for causing. They call it Special K on the street sometimes. Uh, it replaced heroin as now, hun. No, just no. I'm not saying you're a drug addict. I'm just giving you context. Okay, so ketamine is often used for end of life pain care, and it causes a floating sensation. And because it causes a floating sensation, it was very popular at raves for a while. And it used to get cut into ecstasy and stuff like that. So ketamine is known for ureter irritation and inflammation. Have you? Do you live in an urban environment or a rural environment? Are you in the United States? Okay. Um, and you had a pelvic floor assessment, and they said your pelvic floor is normal. Okay. As an ice skater, have you sustained multiple falls? I mean, you had to have as an ice skater, right? So I want you to go back into your think about your history as an ice skater for a moment. Oh, your son. Okay, okay, cool. If your son made the account, okay, then that's good. We can rule that out. Urgency. Okay, so your bladder has two functional nerve systems. You've got alpha afferent nerves, and the alpha afferent nerves are nerves that are very easy to turn on and hard to turn off. These are the nerves that your body uses all day, every day, because they're the ones that tell you when you're full and they're the ones that tell you when you need to pee. So, anytime you sustain some sort of bladder thing, your first symptom is going to be frequency urgency. Okay. First symptom to appear, last symptom to go away. The second nerve group is the C fiber. That's the pain nerve. That nerve group is much harder to turn on. Generally, it requires some sort of trauma to turn it on. Okay. So the fact that you have urgency tells me that it's the alpha afferent nerve in your bladder wall. Hun, can you tell me how old you are? Okay. Are you still having periods or have you had a hysterectomy? Okay. Are your periods normal or are they painful and bloody? Extra bloody. Are they normal? Do you have a lot of cramping? Do you have well water or city water? Okay, well water or city water? Do you have allergies? Like hay fever? Yeah, okay. I agree with you. That's kind of the direction I'm going. So, Hockey, do you have allergies? No, honey, we're not talking about treatments yet. Till I'm still trying to understand your anatomy, my dear. Hold on, just hold on. Do you have allergies? Any allergies at all? Any hay fever? Anything like that? Remember, you're an anatomical mystery to be solved. We don't talk about treatments until I have a clear idea of what your body looks like, of what your anatomy is telling me. Because your ureter inflammation is really weird. That's not normal in IC. I I think you need to get your water tested. She's not talking. She's not answering right now. You need to get your water tested, especially if you're in a farming community, um, because that ureter inflammation implies, in my opinion, kind of some sort of daily irritant. And we see it all the time. We see a well water that's been contaminated by pesticides, anything at all like that. Your county health department should have a water testing service. You should be able to just call them and have them come test your water. That would be one thing I would really want to rule out, because that is just not normal in any way, shape, or form to have ureter inflammation. And again, the very first thing that came to mind was that chemical irritation from the ketamine. I don't think it's ketamine, but I think there might be something else in your environment which is provoking you and contaminating your water. I think that that's one thing that we need to check out. The second thing is, would Botox help with the urgency? It might. It might. With extreme urgency, that tells me that the alpha afferent nerve is really pissed off right now. And so I think number one, diet modification is critical. You got to change your diet. You cannot be doing any soda, any coffee, any green tea, any black tea, any multivitamin. Let's clean up that diet and understand that if you were drinking even 1 cup of coffee a day, that could easily explain massive urgency. And I talked about that earlier. Okay, so let's eliminate chemical irritants if at all possible. The second thing that we need to consider is menopause. Remember that your bladder relies on, so here's that three-dimensional, your bladder relies on a layer of mucus to protect it. So it's almost as if your mucosal barrier is not as strong as it should be, which we would normally see in somebody who is perimenopausal. If your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. So thus that means that the alpha afferent nerve is more exposed. So that could explain your urgency as well. The third thing that we could look for, again, the reason why I was asking about, your periods and stuff like that, is also, is there any chance that you have endometriosis or fibroids, which could be impacting the bladder directly in some way? That's a possibility. Lyme disease, we know that the bacteria from Lyme disease can accumulate in the bladder wall. So could you have some sort of chronic infection in the bladder wall that could be triggering it? Possibly. You are the perfect candidate for this next generation urine testing. I would, given your case with your extreme urgency 24 hours a day, this to me is an important piece of the puzzle. I would really want to know if you have any chronic bacteria, any chronic infection that typical urine testing would not find, but even more importantly, fungal infection. So, you ask, would Botox be helpful? The answer is maybe, but it's not going to get to the root of the problem. We want to try to understand the root of the problem. If you could take a break off of your well water and go on spring water for a month, that would be really, really an interesting experiment. It would be a fascinating experiment to see if that made a difference or not. Okay. If you want to call me after this week, I would be more than happy to talk with you guys. I talk to patients no charge all the time. That's what I do almost every day. And in fact, what we're going to do is I'm going to just start having open office hours on Twitch. So live support on Twitch probably every day or every other day for a couple of hours. Will you just be able to come in and ask a question? And if I'm here, I'll be happy to take it for you. And then we'll be able to have multiple speakers. So I'll be able to bring in some of the big doctors where you can see both of our faces and we can take questions from both of you. All right. So I think for IC Awareness Month, I'm really thinking about doing another online conference, but doing it on Twitch, doing it that way. All righty. So last call. Listen, we've been at it for 3 hours. Amazing. You guys are awesome. Last call for questions. Last call for questions. Angelique says, you spoke about urinalysis test in your live feeds. Can you repeat the information? Urinalysis is basically a 100-year-old technology where they try to grow bacteria on what we call an agar plate, a little round plate. It's got a little jello-like substance in it called agar, which can feed certain bacteria. So when you put urine on an agar plate, it will grow stuff out. The problem is the agar only will grow out the bacteria that eat that food. Some bacteria eat other foods. Fungal eat other foods. So urinalyses today are considered pretty outdated. They can't grow out about 90% of the stuff that's out there. And so the next generation urine test is really the next level of testing that many physicians are now going to. Unfortunately, local doctors often don't know about it. You will be the educator. Go to bladderhealth.org and watch the videos of doctors and how they use it. And I think you will find this mind-blowing. Kim Franklin says she paid $896 for a urine test through a periomics in Virginia, showed embedded infection and fungi, was on strong antibiotics for 14 days, didn't help at all, money wasted. Well, Kim, the microgen test is $199, so you could have saved $700 if you tried the microgen. But I think that there's a flaw in your thinking. In the sense that you have to remember that there are lots of different bacteria in our bladder every single day. They're meant to be there. We're still trying to understand that urinary biome. And some of them may be biofilm. You may need a biofilm buster. I've got a company that's working on a biofilm buster right now. But sometimes 14 days isn't enough. If you've had infection for 10 years and chronic infection, deep tissue infection, maybe it was the wrong antibiotic. Maybe it's not a pathogenic bacteria. It's all the cutting edge stuff that we have right now. Robin said she had real bad urgency and frequency and tried Claritin and it helped a lot. Yes, Robin, that's why I asked Hockey Player if she had allergies. Because we know that if you've got a mast cell syndrome, if you've got allergies, they will absolutely flare during allergy season. And using hydroxyzine, also known as Atarax or Vistaril, which is an antihistamine, can dramatically improve those symptoms. Amanda's using kefir yogurt. Awesome. Angelique's using reverse osmosis water at Whole Foods. Cheap. All right, my friends. Again, Hockey Player, please feel free to contact me through the IC network, 1-800-928-7496. The phone number is right on the website, right on the top of the website. Be more than happy to talk with you a little bit more in depth. Guys, if you like these meetings, could you please subscribe to our Facebook page, share it on your Facebook friends pages, because I'm trying to bring good quality information to Facebook. On YouTube, please subscribe to our page on YouTube. Everybody on Facebook, if you could go over to our YouTube channel and subscribe, that's great. because I need to get 10,000 subscribers to be able to offer more things. And I think right now we're at like 3,500. So please, we need more. All right. Listen, I always end these meetings perfect for Easter. It's perfect for Easter right now. And that is, this is a time for forgiveness and a time for love. And I want you to forgive your body, and I want you to forgive anybody in your life who is at this point in time making it harder for you rather than easier for you. Listen, you're no different than someone who is hit by a car. You're hurt. You're hurt. And you deserve the same love and compassion that you would give to somebody in your family who has a broken hip or a broken leg. You deserve that exact same love and compassion. The challenge is, this is embarrassing. You don't want to talk about your bladder to certain people, and I understand that. But there comes a time if people should start telling you that this is all in your head, that you need to show them pictures, show them a video, show them one of these broadcasts. Better yet, you can call me and I can go on speakerphone with them and answer any questions they might have about this. I want you to be comforted. I want you to be held. I want you to be supported. I want you to be treated kindly, just like I want you to treat people who in your life who are kind, because they may not understand. One of the mistakes that patients make is, here you are, you're having a terrible day all day, and your family's gone, the kids are at school, your husband or your partner's at work, and you're at home suffering. And at the end of the day, they come home and you spill. It's like, oh, it was the worst day ever. My bladder was screaming. I didn't know what to do. And you unload. You unload on your partner. And no matter how hard they try, they can never say what another IC patient can say. Because if you said that to me, I would say, oh my God, I totally get it. I had the same thing happen to me, right? And you have to understand that somebody without bladder pain who's never been here before, they're not going to be able to say what you might need to hear. That's why you've got support groups. That's why you've got your IC buddies. You need to make a team of a couple of IC patients in your inner circle so that you can call them during the day and share how you're feeling. You can come to the IC network, come to a live stream, whatever, so that by the time your family gets home, man, you're together. You understand it. Like the time I made black bean soup, it had a wicked IC flare. And I came on the next day and went, oh my God, has anybody had a flare from black bean soup? I just about died last night. The pain was so bad. Nobody in my family understood that, but I got online and like 5 people were like, oh my God, yes, black beans are really, really acidic. I didn't know. So I need you to cultivate a couple of IC friends, okay? But I don't want you to be online all day. I mean, seriously, don't. These are phone friends. These are in-person friends, okay? If you're feeling depressed and upset, the last thing I want you to do is to come onto Facebook and read IC groups or even our own IC network forum. What I need you to do is my kind of 3-step recommendation every day. Number 1, for 15 minutes, do something to nourish your spirit and your soul. I don't care what it is. It can be going to church. It can be hugging a redwood. It can be playing with your dog, sitting out in the sun, counting butterflies, whatever. Do something that gives you comfort. That gives you comfort. For me, it's listening to Joel Osteen in my car. It's amazing whenever I turn it on. It's like exactly what I need to hear that day. Then, for 15 minutes, I need you to do something for your bladder or for your body. It means follow the diet, do your stretches, call the doctor, make an appointment, try something new. It's your job. You're hurt. You have to create an environment that will support your healing. So if you're drinking soda every day and killing your bladder, that's your fault. I had a lady, a true story, I spent at least an hour with her on the phone explaining IC. She was in terrible shape, very distinctive voice from New York. I'll never forget her voice. Referred her to literally one of the best doctors in the world who worked just down the street from her, right? She calls me back 5 years later. She is sobbing in pain. Oh my God, Jill, I don't know what to do. Nothing has worked. Nobody's helping me. I've tried everything, yada, yada, yada. Everything. Man, she just unloaded. Okay. So we kind of went through her symptoms. She had pain as her bladder filled with urine, relieved by urination. I went, so hun, gosh, you know what? That really sounds like a diet-induced flare. Are you following the diet? She goes, absolutely. Oh, her husband was on the phone. He goes, are you kidding? She's never followed the diet. She drinks a pot of coffee a day, followed by a six-pack of Diet Coke a day. You should have heard her. She was hysterical. She started screaming at him, saying, how dare you take away what I love? How dare you? I have nothing to live for if I can't have my coffee and my soda. And I'm listening to this going, oh my God. And I said, now, wait a second. I told you about the diet. Didn't you believe me? She goes, no. I said, I sent you to Rob Moldwin, one of the best doctors in the world, the author of the IC Survival Guide. He told you about diet. Did you believe him? She goes, no. I said, you have seen 6 or 7 doctors. Did they all tell you about the diet? She goes, yes. Did you believe them? She goes, no, it didn't apply to me. And I went, no, you're an addict. You're an addict. And she got all huffy, and it's like, all right, how much money have you spent on your IC treatments in the last 5 years? She goes, $50,000. I said, do you realize you have sabotaged every single treatment you've ever tried? She goes, what? I said, you've sabotaged them. None of them had it. None of them had a chance to help you. She goes, what? I said, $50,000 wasted. She goes, what? I said, listen, there's no treatment that can counteract the damage done when you drink a pot of coffee and diet soda all day. You are damaging your bladder so profoundly. There is no treatment that can rescue you, period. End of story. You have sabotaged every single treatment you've tried because you didn't believe that diet mattered. By this time, she was like, oh my God, she was like, oh. And then I explained the stem cell. You got the bladder wall, largest single cells in the human body. Looks like a giant pizza. One little tiny pea underneath it, a stem cell. That upper cell's damaged. That stem cell has 2 weeks to grow and change shape and change size to fill in that spot, right? 1 soda a day will kill it. She was drinking 6 sodas a day and a pot of coffee. Her bladder had never had an opportunity to repair itself. So she was like, and her husband's on the phone, was like, honey, I told you. I kind of let her have it. She called me back 3 months later. Oh my God, Jill, you're not going to believe it. What? And I was like, what? She goes, I finally stopped the coffee and the soda. I'm like, oh God, that's great. She goes, no, you don't understand. I'm way better. It's like, I know. I know you're better. I know you're better. You didn't understand. You were sabotaging your healing. Okay. So we're getting back to the 15 minutes a day. For God's sake, take that 15 minutes and do something good for your bladder, not bad for your bladder. You may not drink a pot of coffee and a 6-pack a day. If you've got bladder wall driven Hunner's lesions, seriously, your job is to create an environment to support healing. That's water, chamomile herbal tea, peppermint herbal tea, milk, and maybe rooibos tea. End of story. Okay. Last but not least, I need you to do something to improve your knowledge. I mean, here with this woman, she really never read the book. She didn't come to the website. She didn't read about anything because she was massively addicted to caffeine, right? I need you to build your knowledge level up because no one can ever tell me IC's in my head. I will slam dunk them with research. And I want you to be able to do the same thing, to slam dunk them with research. All right. So that's your homework. I'm going to do a drop-in meeting probably this week again. But what I want you to do is pay attention to announcements on Twitch about Twitch TV because I'm very anxious to get that up or to get our Discord channel up again. I just have to have a team of moderators. If anybody at all is interested in moderating a live voice channel or Twitch TV or even the IC Network Forum, please reach out to me. I love moderators. You will have the benefit of all of my knowledge. I will train you to the nth degree so that you can be a good advocate for IC patients. And we are a team. We are a team, my friends. We are a team. We are doing it together, right? Right. You are not alone. All right, my friends, listen, I got to go fix Easter dinner. I'm going to wish you the best. Carry hope in your heart every way. As always, you can reach out to me directly at the IC Network. Please come on over and do it. www.ic-network.com. Sign up for our newsletter so you get the announcements about all the changes. Okay, be well. Goodbye, Facebook. Amanda says on Facebook, bread causes inflammation too. Yeah, a white bread certainly does. No doubt about that for me. All right, bye, Facebook. And YouTube. Last call. Everybody on YouTube, see you. I'll see you later. Have a good one. Happy Easter, everybody.